welcome to Dr. Shyam, Mithiya. Yes, so uh, it's and I'm really thankful to everyone. It's to join in this early in the morning. I know it takes little effort to actually get up, get ready, and then become part of a webinar. But this is also something that is so important to all of us that it needs our effort to be here. And when we have eminent doctor like Dr. Shyam Mithiya, I mean, we should not miss this opportunity to listen to him, to ask him questions, and benefit from this session. Uh, this is Dr. Visham. This is my second session with you. One was in person last year when we had
I
done
know.
in one of the Mumbai colleges, and today this is
Yes.
the virtual one I am having with you. And before I introduce you, I would like to say that you are a wonderful orator because that is not part of your description that I'm going to be telling the team here that has joined. But you are a wonderful orator, and I would say that he has an incredible ability to enthrall his audience by his speech, by his knowledge. So, a gifted, eminent doctor with such wonderful abilities, I think we are going to have a wonderful time. So, just moving ahead from here. Uh,
Thank you so much. Thank you so much for such a beautiful, beautiful introduction. I think I should make you listen. My wife should listen to you so that she also starts understanding me.
just a
Thank
minute,
you.
something's wrong on my screen. I'm trying to share.
No worries,
Finding
but
that.
I'm glad and I'm happy to join this, and I'm really grateful for such a beautiful introduction, Krantiji.
Thank
Thank
you.
you so much for that.
Yeah. So I'm just getting on to my next, for everyone to know in more detail about who our guest today is. So we have Dr. Shyam Mithiya, as I said. Uh, he is an MBBS, MD, DPM, super specialization in psychiatry. He is a wonderful counselor as well. He is one of the top psychiatrists practicing in Mumbai today. Uh, a member of the Indian Psychiatric Society of Bombay and Bombay's Psychiatric Society. He has many awards and prizes under his belt. So he is a renowned uh, person that who usually features in newspapers. You will see him on the channel, TV channels. You would see him also on the radio channels, like various FM channels. So he contributes a lot in the world of psychiatry. Uh, he was awarded as the best neuropsychiatrist and sexologist in Mumbai by India Healthcare Awards 2016. He was also awarded as the most admired consultant neuropsychiatrist and sexologist from APS Media Service Quality Awards Asia and IBN 7 News Channel 2016. So I'm going to deep dive into two or three more achievements of his, but just to point out, his areas of interest are psychiatry and counseling, and he's a practicing psychiatrist and a sexologist. So the next slide that you see on my screen here, you will see that he is the recipient of the Most Admired Consultant of the Year award, consistently featured in leading newspapers, as I said, national papers, Mumbai papers, featured in various magazines like New Women's Magazine. BBC News featured an article with views of our doctor here. He has appeared as an expert in panel discussions, like I said, on various TV channels and also radio shows. And the most recent feather in his cap is where he's featured as in the list of eminent doctors in Mumbai for the year 2024. So this is done through an extensive survey at peer group, etc., that NEB Media uh, conducts. And hardly 8 to 9 doctors are selected, and Dr. Shyam is one of them. So, Dr. Shyam, congratulations from all of us for being featured here. And we are
Thank you so
so
much.
thankful,
And
for that you have spared time for all of us here today.
I would really request you, please don't keep saying that. That embarrasses me. I'm really honored. I'm really happy, really privileged to be here amongst all of you. All of you are doing such a brilliant work. The whole Multiple Sclerosis Society of India, including the Mumbai chapter, is really doing a wonderful work in helping all the MS patients all around with whatever is required, destigmatization and other things required. And I'm really glad, honored, privileged, and blessed to be here amongst all of you. It is blessing. See, I am just 41 right now, and it is blessing to be amongst all of you, and all that really keeps me motivated, and yeah, it helps me do what I'm doing. So thank you so much.
Thank you. So, for the audience that we have here today, um, you all can keep typing your questions in the chat. And as we go ahead, we will keep taking these questions. Most probably, we'll take them towards the end. But if there is something that comes across as relevant as we are at that point of discussion, we will pick up those questions as well. And
We'll have mixed audience, right? We'll have audience who speaks and understands English
yes,
as well as
yes.
Hindi.
Yeah,
So
yeah,
we would, yeah, yeah, yeah.
yeah.
So we,
And
we, we would like to keep the session like that.
yeah, and there is one thing that I
Mm.
always forget to do is introduce myself. So once again, I'm Kranti Munje. I'm the Honorary Secretary of MS Society of India's Mumbai chapter. I'm also an MSP for almost 16 years now, and have been associated with MS Society for the last close to 16 years. So that's me here.
I should have,
And
I should have done that, but see, these are the things I need to still learn, right? I should have done that.
no,
Pleasure to be with you, Krantiji. Pleasure to be with you.
yeah, same here. So, what we would do is, Doctor, we are going to keep it conversational, like what we have discussed. And let's start probably with something, because, depression is such a word that I'll tell you in my journey of last 20, 30 years, when I got connected with psychiatry as a subject, depression being a myth. From that myth, it became a condition not to be spoken about. And today it has reached a point wherein everyone says, oh, I'm depressed. So even if that person is feeling depressed for a minute, the person will say, I'm under depression. If the person is feeling sad, I'm feeling depressed. If person is feeling bad, I'm feeling depressed. So, all these family of emotions wherein there is sadness, there is anxiety, there is I'm feeling bad, all of them today become depression. So, I think from my point of view, I would like you to explain all of us what is depression, and when do we say that someone is under depression, because that is, I think, a very important aspect of managing depression before labeling it and before self-labeling it. Let the doctors come and label what you have, but we ourselves labeling probably should not be done, is my thought. So over to you.
I think this is a very important point what you have just spoken about. Uh, from the stigma of not speaking about depression to everyone saying I'm depressed. I think that's the journey what we are having. So stigma was not only depression, any mental health issues. कोई भी mental health issues हुआ तो उसके बारे में बात नहीं करनी है. डॉक्टर के पास जा रहे हैं तो बात नहीं करनी है. डिप्रेशन इश, एंजाइटी इश, ओसीडी इश, कोई भी मेंटल हेल्थ इशू हुआ किसी भी फैमिली मेंबर को, फ्रेंड को, दूसरे क्लोज रिलेटिव को, नेबर्स को, उसके बारे में बाहर बात नहीं करनी है. और तो और पेशेंट जा रहा है डॉक्टर के पास, उन्होंने ट्रीटमेंट लिया, वो इम्प्रूव भी हो चुके हैं. इवन आफ्टर दैट दे डोंट वांट टू स्पीक अबाउट, दे वेंट टू डॉक्टर, दे got treated, they took medicines, they took therapy, and they are completely cured and completely out, back to fully functional what they were, or even better than that, because they have gone through that crisis and they have gone through that टर्बुलेंस. तो उसके बाद और ज्यादा मैच्योर और ज्यादा अंडरस्टैंडिंग के साथ पर्सन बाहर निकलता है, लेकिन बाहर निकल के कभी वो ये नहीं कहते कि भाई मैं तो डॉक्टर के पास गया था, मुझे डिप्रेशन हो रहा, कोई भी.
ये पता है डॉक्टर,
अब
मेरे एक्सपीरियंस में क्या है कि जो
हाँ,
साइकियाट्रिस्ट है, और मैं ये आपको 50-60 साल के, फॉर दैट टाइम फ्रेम आई एम सेइंग, आई एम नॉट टॉकिंग बियॉन्ड दैट, मगर वो
राइट,
है कि साइकियाट्रिस्ट पागलों का डॉक्टर है।
ट्रू,
और
ट्रू,
जो साइकियाट्रिस्ट के पास हेल्प के लिए जाएगा, यानी वो पागल है, पागल ही
ट्रू.
सिर्फ पागलों के डॉक्टर के पास जाता है। तो इसीलिए मेरे हिसाब से शायद ये स्टिग्मा इस वजह से है कि हम जब अपने माइंड की बात करते हैं, तभी लोगों को लगता है कि जब साउंड माइंड नहीं है, यानी सिर्फ पागलपन है।
Absolutely. बहुत आपने एकदम pinpoint, you have nailed it. I think the classification of mental health diseases or mental health issues or mental health illness, if a person is going through any mental health issue, it is person is crazy. Whereas वो जो layman crazy का definition है, वो extremely violent या extremely people who are disturbed, those are 1%. 99% of patients are like you, me, or anyone else who can have symptoms or some form of mild, moderate illness any time throughout our journey, whether it is depression, anxiety, OCD, phobia. बहुत सारे illnesses हैं जो बहुत mild होते हैं, moderate होते हैं, जिसके जो किसी को भी हो सकते हैं, कभी भी हो सकते हैं. And in those diseases, in those illnesses, person doesn't act completely abnormal or crazy. तो ये डेफिनेशन ही गलत है कि मेंटल हेल्थ इशू मतलब क्रेजी. तो इसीलिए ये स्टिग्मा की वजह से ही जब बहुत सारे लोग जाते हैं डॉक्टर के पास ट्रीटमेंट लेके, इम्प्रूव होने के बाद, दे नेवर स्पीक अबाउट देयर इम्प्रूवमेंट एंड देयर प्रोग्रेस एंड देयर जर्नी. और कौन से केसेस बाहर बोले जाते हैं जो शायद बहुत रेजिस्टेंट है, बहुत सीवियर है, जो इम्प्रूव नहीं हुए, कि वो फलाने को देखो, वो 5 साल से दवाई ले रहा है, वैसे का वैसा ही है, कोई इम्प्रूवमेंट ही नहीं है. वो पर्सन को देखो, इतने टाइम से दवाई ले रहे हैं, पूरा दिन सोए रहते हैं, कोई इम्प्रूवमेंट ही नहीं है. सो फॉर अनफॉर्चुनेटली देयर आर केसेस हु आर वेरी सीवियर and who might need medications for lifelong, or those are severe cases. And उसमें इम्प्रूवमेंट एक लेवल तक आता है, एक होता है, नहीं होता है, पेशेंट दवाई बंद कर देते हैं, इसके लिए रिलैप्सेस होते हैं. तो वो केसेस लोगों को दिख रहे हैं, लोग उसके बारे में बात कर रहे हैं, लेकिन जो इम्प्रूव होके कंप्लीटली ऑफ मेडिकेशन है, उसके बारे में लोग बात नहीं करते, वो खुद कभी बाहर आके बात नहीं करते. वही सबसे बड़ा प्रॉब्लम है. वही वहां पे भी मैं एमएसएसआई को बहुत ज्यादा एक फिर से थैंक यू कहना चाहूंगा कि आप लोगों ने जो सोसाइटी फॉर्म की है, आप लोगों ने जो the work what you're doing, I can see the support group, I can see people coming out and telling that they are going through this, and they can see that they have that support system. So really, really big applauses to you. Coming back to our point, man, you will have to keep me, otherwise I'll keep
या
going
या या
here and there. So stigma, because people don't open up and they improve. And the second point of everyone saying I am depressed, depression को अभी एक स्लैंग की तरह यूज करने लग गए. सैडनेस को, अगर कुछ हुआ, मैं कहीं खेल रहा हूं, मैं हार गया, तो आई एम अप्रोप्रिएटली सैड, दैट इज नॉट बीइंग डिप्रेस्ड. अगर मेरे फैमिली में कहीं पे कहीं कुछ हो गया एंड मुझे अप्रोप्रिएटली सैडनेस आया, उसके लिए टर्म ही लोग डिप्रेशन यूज करने लग गए. दैट इज नॉट डिप्रेशन. डिप्रेशन इज अ क्लिनिकल कंडीशन. आप अगर डेफिनेशन जानना चाहोगे तो डिप्रेशन इज अ क्लिनिकल कंडीशन जिसमें persistent sadness है. Person is going through persistent sadness with loss of interest in day-to-day activities, to the level where it starts impacting your professional, personal, and social life. And it should last at least for 14 days or more, and beyond that. So person has to have sadness of mood, loss of interest in whatever activities he or she was doing, and it is persistent, and it is to the level where it is impacting your professional, personal, and social life. That is clinical definition of डिप्रेशन। एंड जो हमको डे टू डे में बहुत सारे लोग जो स्लैंग यूज कर रहे हैं, दैट इज नॉट डिप्रेशन, दैट इज जस्ट appropriate sadness, which is a human emotion, which will be there for all of us, which is required and which will be there. That is not depression.
Yeah. सो डॉक्टर, एट व्हाट पॉइंट, कौन से पॉइंट
Hmm.
पे हम लोगों ने आप आप जैसे डॉक्टर को मिलना उचित होगा, ये अगर आप हम सबको बताएं तो अच्छा होगा। मगर वहां तक वो पॉइंट पे जाने से पहले तो आई वुड लाइक टू फोकस ऑन एमएस एंड डिप्रेशन रिलेटेड टू एमएस, बिकॉज काफी बार तो एमएस के पहले अटैक से ही के बाद ही शायद वो सेट इन हो जाता है। मे बी सम ऑफ इट कुड बी clinical in nature, wherein it is the part of the MS as a beast, कि वो as a
Right,
package deal आ जाता है। And
right,
another is also the emotional turmoil that patients go through, because all of a sudden in a minute you realize, oh, from a standing person I have become a complete flat on bed kind of a situation होती है। मेरी वैसी ही हुई थी। So I know, one moment I'm standing and next moment I'm completely flat on the bed, completely almost fully disabled, blind, disabled. So that itself एक emotion का इतना सैलाब आ जाता है अंदर कि it is so difficult to deal with. So if you could explain to us from MS point of view something that comes as a package deal and something that comes as an emotional turbulence that patients go through.
right. I think again, absolutely, what you're saying is absolutely right. In MS, depression would come as two different in two different ways. First thing is because MS itself is a disease of central nervous system के इसमें nervous system की ये disease है जहाँ पे जो myelin होता है, जो nerves की जो covering होती है, उस पे impact होता है एंड वो कम हो जाती है, इसीलिए ये इलनेस होता है। बिकॉज इट इज अ डिजीज ऑफ सेंट्रल नर्वस सिस्टम, तो उसकी वजह से भी डिप्रेशन कैन कम इटसेल्फ एज अ पार्ट विथ मल्टीपल स्क्लेरोसिस के सिम्टम्स, जो दूसरे सिम्टम्स जो भी आते हैं, वेदर इट इज वीकनेस, वेदर इट इज विजन इश्यूज, वेदर इट इज कोऑर्डिनेशन इश्यूज, वेदर इट इज लॉस ऑफ बैलेंस, ऑल जो भी सिम्टम्स आते हैं उसके साथ डिप्रेशन कैन इटसेल्फ कम एज पार्ट ऑफ सेंट्रल नर्वस सिस्टम। दैट्स वन वे इन विच डिप्रेशन कैन कम। एंड द सेकेंड इज, अगर वैसे भी नहीं आ रहा है तो बिकॉज जैसे आपने एकदम सही से कहा, पर्सन ऑन वन मोमेंट इज completely फाइन and second moment suddenly it can be rapidly progressive and acute, where person realizes कि suddenly ये सारे symptoms आ गए हैं, and then when he or she is visiting doctor with proper diagnosis, if it is diagnosed as MS, then एक पूरी दुनिया हिल जाती है कि भाई ये क्या हो गया, मैं अभी तो सब कुछ सही था। इट तो MS कैन कम एज वेरी रैपिडली प्रोग्रेसिव, इट कैन कम एज वेरी स्लोली प्रोग्रेसिव, दोनों फॉर्म में आता है। but in both the forms, when person realizes that he or she was all okay and suddenly उनको ये symptoms आ रहे हैं, तो एक जो शॉक लगता है, जो एक इम्पैक्ट होता है, दैट कैन ऑल्सो ब्रिंग इन डिप्रेशन। एंड अगेन, जब मैं डिप्रेशन कह रहा हूँ तो मैं ये नहीं कह रहा हूँ सिर्फ सैडनेस ऑफ मूड नहीं आ रहा है डिप्रेशन में, कैसे जो सिम्टम्स हैं डिप्रेशन के, क्या क्या रहे सिम्टम्स रहेंगे तब मैं सोचूंगा कि ये डिप्रेशन है। तो इट वुड बी अगेन एज आई टोल्ड यू, सैडनेस ऑफ मूड, एक मूड उदास होना, चिड़चिड़ापन होना, क्रैंकी होना। इट वुड बी लॉस ऑफ इंटरेस्ट इन डे टू डे एक्टिविटीज, जो एक एंथुजियाज्म होता है, उत्साह होता है मेरा, मेरे प्रोफेशनल लाइफ में, पर्सनल लाइफ में, सोशल लाइफ में, जो भी मेरे उत्साह होता था, जो चीज़ें करके मुझे खुशी मिलती थी, म्यूजिक, रीडिंग, राइटिंग, पेंटिंग, आज वो चीज़ करने में मुझे दिल ही नहीं करता, या करूंगा तो भी द अमाउंट ऑफ जॉय और प्लेजर विच यूज टू बी देयर, दैट इज मिसिंग। दैट्स नंबर टू। नंबर थ्री, मेरी नींद बहुत ज्यादा बढ़ गई, बहुत ज्यादा कम हो गई, स्लीप डिस्टर्बेंस। नंबर फोर, खाना, मैं सडनली बहुत ज्यादा खाने लग गया हूँ, बहुत कम खाने लग गया हूँ, एंड बहुत बार वेट वेट लॉस या वेट गेन, एंड दैट कैन हैपन विदाउट appropriate changes in the appetite also. तो मेरे खाना सडनली चेंज हो रहा है। नंबर फाइव इज साइकोमोटर एजिटेशन और रिटार्डेशन। सिंपल लैंग्वेज में, मैं बहुत यार एकदम स्लो हो गया हूँ, या एकदम से रेस्टलेस एंड एजी एंड चिड़चिड़ा हो गया हूँ। फटीग, पूरा दिन थकान रहनी, दैट कुड बी MS, दैट कुड बी बिकॉज ऑफ डिप्रेशन। तो वो कंफ्यूजन भी होता है बहुत, ही MS के ही सिम्टम है और डिप्रेशन तो नहीं है, तो फटीग इज वन थिंग। loss of interest in, as I told you, most of the things, which includes day to other pleasurable activities, sexual in life में भी suddenly interest चले गया है. These symptoms can come with, of course, some severe symptoms like suicidal thoughts, concentration जा रहा है, जीने की इच्छा एकदम से कम हो रही है. तो जब ये symptoms आ रहे हैं, इसमें से 3-4 symptoms persistent आ रहे हैं, तो डेफिनेटली आप अपने न्यूरोलॉजिस्ट को जाके दिखाइए, हु would definitely refer you to a mental health professional, जिनके पास जाके आपको diagnosis समझ में आएगी कि these can be part of depression or these are just temporary symptoms and this could be only part of MS, and दोनों केस में उसको कैसे टैकल करना है वो हम आगे प्लान कर सकते हैं.
Yeah. Because I think initial stage में तो because हम लोग especially when either some disability sets in, या all of a sudden, like in my case, all of a sudden सब कुछ बंद हो गया. तो during that time the thoughts of depression are also because कि आप इतने helpless feel कर रहे हो and you don't know how to deal with the world now, or what do you do with your life and what do you do with the life that is around you. For example, if you have children, if you have family, if you have responsibilities, all of a sudden that itself becomes a big question mark. And I think sadness, a lot of sadness can come through this helplessness also. Am I correct?
Yes, absolutely. That can, as we already discussed. In fact, मैं वो specific word use करने भूल गया जो आपने बहुत अच्छे से pinpoint किए. Person starts feeling helpless. Person starts feeling hopeless about the future, and certain times person starts feeling worthless. So classically, patients आके ये describe करते हैं, and then those are specific words people use and very specific of the diagnosis of depression.
Yeah, yeah.
Mm.
Just, as my experience, I can share, it may help
Yes,
others
please.
also.
Of course,
And
200%.
yeah, so when I had my MS and I was completely grounded, in 2 days, I was completely grounded. So that time, I used a therapy on myself, and I knew of this therapy because I had read a book by Dr. Viktor Frankl. And जो डॉक्टर विक्टर फ्रैंकल को, आई एम श्योर यू नो डॉक्टर विक्टर फ्रैंकल, बट पीपल जो डॉक्टर विक्टर फ्रैंकल का नाम नहीं सुना है, उन्होंने, वो जू थे, हिटलर के नाजी कैंप में उनको लेके गए थे, एंड ही वॉज पुट अंडर द कॉन्सेंट्रेशन कैंप जहाँ लोगों को मार दिया जाता था. सो ड्यूरिंग दैट टाइम he stayed alive, and then he wrote a theory on what he experienced and how he stayed alive, and he called that theory as logotherapy. So his a small book is there, Man's Meaning for Life or Man's Search for Meaning. The name is something like that. तो वहां उन्होंने कहा है कि एक अपना अ, आप एक कोई तो ध्येय निकालो. जस्ट what is your biggest motivation at that point in time? So people should identify their biggest motivation and then get motivated to achieve that. And that keeps you actually moving, and that takes you through all the turmoils that you are going through. And I use this for me to come back to my life in 3 months' time.
Superb. मतलब I think this is incredible. मतलब मैं आप when you started and you repeatedly telling me thank you for joining us and from your busy schedule and all that. I मतलब मैं सिर्फ बोलने के लिए नहीं बोल रहा था. I really mean it when we meet people like you and all the people. शीला जी बोलिए आप, ये सभी लोगों से जब मिलते हैं, it is really inspirational, and these are the examples we sometimes give to our patients going through depression. कि कि आप अगर सोचोगे तो आप 200% ये चीज से बाहर निकल सकते हो, और ऐसे बहुत सारे एग्जाम्पल हमने हमारी आंखों से देखे हैं, एंड दिस इज 200% पॉसिबल, have been done in past and you can do it in the present. विक्टर फ्रैंकल के बारे में कुछ कहूंगा, लेकिन उसके पहले मैं आपके जो एग्जाम्पल हैं उसके थ्रू मैं और कुछ कहना चाहूंगा कि व्हेन इतनी बड़ी सडन डायग्नोसिस आती है, सडन लाइफ चेंज आता है, इट कुड बी sudden diagnosis like this or any other major life changing event, whether किसी के फैमिली मेंबर को कुछ हो गया, किसी के स्पाउस को कुछ हो गया, सेपरेशन हो गया, एग्जाम में फेल हो गए, रिलेशनशिप ब्रेकअप हो गया, मैं ये सभी एग्जांपल ले रहा हूँ क्योंकि ये भी एक बहुत अक्यूट मेजर लाइफ चेंज है, इंक्लूडिंग द डायग्नोसिस ऑफ एमएस। ऐसा जब मेजर चेंज आता है तो पर्सन कैन गो थ्रू डिफरेंट स्टेजेस। द फर्स्ट स्टेज is denial, कि the person feels ये ये नहीं हो सकता है मेरे साथ, ये पॉसिबल ही नहीं है, मैं सब कुछ सही है, ये कैसे हो सकता है, ये मेरे साथ हुआ ही नहीं है, मैं तो सब सही था, ये डायग्नोसिस गलत है, ये पॉसिबल ही नहीं है मेरे साथ होना, ये मुझे नहीं हुआ है और कुछ ना कुछ गलत है एंड दिस इज गोइंग टू चेंज। सो पर्सन इज not accepting that he or she has been diagnosed and he or she is going through this। तो जब तक डिनाइल में रहेंगे तब तक हम और उससे दूर जा रहे हैं और हम उसको एड्रेस करने से और दूर हैं। सेकेंड स्टेज कैन बी एंगर। गुस्सा आने लग जाता है कि मैंने तो लाइफ में सब सही किया है, मैंने किसी का कुछ बुरा नहीं किया है, मैंने कभी कुछ नशा नहीं किया है, मेरे को कोई बीमारी नहीं है, एवरीथिंग व्हाट आई हैव डन इन माय लाइफ हैज बीन, जो मेरे पेरेंट्स ने कहा, टीचर्स ने कहा, जो अच्छा अच्छा है, सब कुछ मैंने किया, उसके बावजूद मुझे ये कैसे हो सकता है, मैंने कभी कोई गलत काम किया नहीं है, नशा नहीं किया है, फिजिकली कोई बीमार नहीं है। सो एंगर, पर्सन इज नॉट रेडी एंड एंगर खुद के पे भी आ रहा है, इससे तो बेटर है ये कर लेता, वो लोग कर रहे थे वो कर लेता, भगवान पे आएगा, दोस्तों पे आएगा, फैमिली पे एंगर। थर्ड इज बार्गेन, कि मुझे एमएस की जगह पे और कुछ भी होता ना, मैं फेस कर लेता, इसकी जगह इसकी जगह मुझे डिप्रेशन होता तो मैं फेस कर लेता, इसकी जगह मुझे और कुछ होता तो फेस कर लेता, मेरी जगह और किसी को हो जाता तो ज्यादा सही था। ऑल सॉर्ट ऑफ बार्गेनिंग थॉट्स इन योर माइंड दैट इससे बेटर ये था, इससे बेटर ये था, इससे बेटर मेरी लाइफ पहले थी, मैं ये करता था वो करता था। सो ऑल दोज ऑफ बार्गेनिंग थॉट्स, अगेन ये पहले तीनों भी स्टेज में पर्सन हैजंट एक्सेप्टेड दैट दिस इज हैपनिंग एंड अगर मूव ऑन करना है तो फर्स्ट फर्स्ट स्टेप है कि वो ये तीन स्टेज से आगे बढ़ना है। एंड फोर्थ स्टेज इज डिप्रेशन, वेयर पर्सन हैज एक्सेप्टेड कि ये हुआ है, बट देन ही और शी इज नाउ स्टार्टिंग टू मोन के कि ये हो गया है एंड पता नहीं ये ठीक होगा नहीं होगा, होपलेस, हेल्पलेस, वर्थलेस, जैसे हमने हमने डिस्कस किया, दैट कुड बी द फोर्थ स्टेज। एंड द फिफ्थ एंड द लास्ट स्टेज इज एक्सेप्टेंस, व्हेन पर्सन एक्सेप्ट्स, ओके दिस हैज हैपेंड, ये हो गया है, इसको मैं डिनाई नहीं कर सकता हूँ, इस पे गुस्सा होके कोई मतलब नहीं है, इस पे बार्गेन करके कोई मतलब नहीं है, उस पे उदास बैठ के भी कोई मतलब नहीं है, इसको एक्सेप्ट किया है मैंने, ये हुआ है, अभी मैं क्या कर सकता हूँ यहाँ से, व्हाट कैन आई डू टू गेट माई सेल्फ रिकवर्ड एज फास्ट एज पॉसिबल, या इसके साथ में और मेरी प्रोफेशनल लाइफ, पर्सनल लाइफ, सोशल लाइफ में मैं क्या कर सकता हूँ, कैसे इम्पैक्ट ला सकता हूँ मेरी लाइफ में, इन पीपल सराउंडिंग मी, इन पीपल who are dependent on me, how can I bring in that meaning to life, Viktor Frankl, meaning to life। So that is the fifth stage, acceptance। और जरूरी नहीं है हर लोग ये पांचों स्टेज से ऐसे स्टेप बाय स्टेप जाएंगे, person can directly go from denial to acceptance, person can go directly to anger, can directly go to depression, directly can go to acceptance also। It really depends on लॉट ऑफ फैक्टर्स, उनके डॉक्टर्स पे डिपेंड करता है, फैमिली पे डिपेंड करता है, सपोर्ट सिस्टम पे डिपेंड करता है। एंड बट द मोस्ट इम्पॉर्टेंट स्टेज एंड द लास्ट स्टेज इज एक्सेप्टेंस, जहाँ पे जितना जल्दी आप एक्सेप्ट करोगे, जितना जल्दी आप रियलाइज करोगे कि ये तो है लेकिन इसके साथ अभी मैं कैसे बढ़ सकता हूँ, जैसे जैसे क्रांति जी आपने किया, एंड दैट इज व्हाई आई एम टेलिंग यू दिस इज इंस्पिरेशनल। The faster you did it, you said 3 months, and then the faster you now what you're doing, and not only you have taken back control of what your life, but you've been helping so many people going through this and making changes in their life, adding meaning to their life, that is so। कहीं ना कहीं adversity ने आप में इतना पावर लाया, जो आपकी लाइफ नॉर्मल चल रही थी तो उससे भी ज्यादा मीनिंगफुल आपकी लाइफ आज के टाइम पे है, वेयर यू आर ब्रिंगिंग मीनिंग एंड सब्सटेंस एंड हेल्प टू so many people all over India and maybe world. So
Thank you
I
for
really
saying
appreciate
that.
and thank you.
Yeah, thank you for saying that.
Yes.
Doctor, can we touch upon the role of hormones? Because, now at least everyone knows that there are hormones that make you sad and hormones that are happy hormones that can, they're like happiness ke injections. So if you could throw some light on this.
Yes, absolutely. So I मतलब terminology layman language में हार्मोन ठीक है, but terminology आप correct word लेना चाहेंगे तो those are not hormones, those are neurotransmitters. But layman,
Neurotransmitters, yes.
हाँ, layman
Yeah,
language
but
में
for layman, it is
yes, आप
happy
उसको
hormones, sad hormones, but they are neurotransmitters. I understand.
हैप्पी हार्मोन बोलो, सैड हार्मोन बोलो, केमिकल लोचा बोलो, मतलब कुछ भी हम बोल सकते हैं, बट वो अब आप साइंटिफिक लैंग्वेज में वो न्यूरो ट्रांसमीटर है, लेमन लैंग्वेज में हमको समझने के लिए हम उसको कुछ भी बोल सकते हैं, दैट इज नॉट अ प्रॉब्लम. सो सेरोटोनिन इज द प्राइमरी एंड द मोस्ट इंपॉर्टेंट न्यूरो ट्रांसमीटर रिस्पॉन्सिबल फॉर डिप्रेशन. जो डेफिशिएंसी ऑफ सेरोटोनिन एंड कि सेरोटोनिन की डेफिशिएंसी की वजह से जो भी सिम्टम्स हमने डिस्क्राइब किए पूरे, लॉस ऑफ इंटरेस्ट, एंथुजियाज्म, एनर्जी, मूड, ड्राइव, सुसाइड, सब कुछ सेरोटोनिन की वजह से होता है. देयर आर ऑफ कोर्स अदर न्यूरोट्रांसमीटर्स, डोपामिन, एड्रेनालिन, ऑक्सीटोसिन, ऑल दोस आल्सो, बैलेंस ऑफ ऑल दोस वुड बी बेनिफिशियल, बट प्राइमरी डेफिशिएंसी अगर आप कहना चाहेंगे हैप्पी हार्मोन, तो दैट इज सेरोटोनिन. इसकी डेफिशिएंसी की वजह से ये होता है. तो अगेन डेफिशिएंसी, जैसे हमने इनिशियली डिस्कस किया, सेंट्रल नर्वस सिस्टम के इश्यू की वजह से ही डेफिशिएंसी होना शुरू हो जाती है, एंड पैकेज ऑफ एमएस के साथ डिप्रेशन फ्री में आ गया है, या फिर एमएस हो गया एंड उसकी वजह से आपकी एक्टिविटीज कम हुई, एंड देन यू स्टार्ट फीलिंग कि अभी मैं कुछ कर नहीं सकता हूँ, एंड दैट इज व्हाई यू स्टार्ट फीलिंग सैड, एंड दैट इज व्हाई depression and the serotonin is going down, and that is why you start feeling depressed.
Yeah.
So
And
serotonin is the neurotransmitter.
yeah, and sure, doctor, like we said in the beginning, जब ये बहुत severe होता है, you can always help patients to deal with this and come out of it through either medication or non-medication therapies, etc. For example, what worked with me last year when I was going through personal crisis and depression was I took to exercising and walking, so almost 1 hour a day, because I thought that could help me, and it did help me. So I'm sure, if people who are going through these issues approach you and doctors like you, that would be of great help for them to deal with their situation, because finally doctor is the best person to know कि क्या देना चाहिए और पेशेंट को क्या जरूरत है.
परफेक्ट. आई थिंक बहुत सही से आपने फिर से बताया है कि पर्सन व्हाट स्टेज ही और शी इज इन, what is the situation, what are the symptoms, and based on the diagnosis of mild, moderate, severe depression, we advise them the treatment options. It is not necessary कि हर पेशेंट को मेडिसिन ही देनी है, एंड इट इज नॉट नेसेसरी कि पेशेंट मना कर रहा है तो मेडिसिन नहीं देनी है.
नहीं दी.
I'll tell you different options that generally people, I there are a lot of uh, lifestyle modification which can really help patients going through mild depression. जैसे exercise हो गया, exercise is one of the most important and बहुत underrated चीज है. When person is exercising, he or she while doing it go through those changes, so neuromodulators release होते हैं, interleukins release होते हैं, तो उसकी वजह से भी बहुत एक खुशी मिलती है, सेरोटोनिन स्लोली स्लोली रीबैलेंस होता है, उसकी वजह से भी फायदा होता है. सो एक्सरसाइज इज डेफिनेटली हेल्पफुल एंड एडवाइजेबल. बट मैं कहीं ना कहीं ये कहना चाहूंगा कि इट रियली ऑल्सो डिपेंड्स ऑन द स्टेज ऑफ द डिजीज. जैसे किसी को डायबिटीज है, अगर वो डॉक्टर के पास प्री डायबिटिक स्टेज में ही चले जाता है कि एकदम बॉर्डर पे शुगर है, एकदम माइल्ड डायबिटीज शुरू हुआ है, तो वो पर्सन अगर बहुत जाके डाइट कंट्रोल कर ले और एकदम से एक्सरसाइज करने लग जाए, तो शायद है कि उनका कंट्रोल हो जाएगा, मेडिसिन हमने स्टार्ट भी नहीं किया. और यही पर्सन है कि 350 शुगर है, 400 शुगर है, और अभी डॉक्टर के पास जा रहा है, और हम आंख बंद करके सेमी एडवाइस, हमको बहुत बार बहुत सारे ये होता है साइकेट्री में, इसने एडवाइस दे दिया, उसने एडवाइस दे दिया, दोस्त ने एडवाइस दिया, केमिस्ट ने एडवाइस दिया, गूगल ने एडवाइस दिया, कि एक्सरसाइज मेरे लिए काम किया था, एक्सरसाइज करने से ही डिप्रेशन दूर होता है, दवाई ववाई सब बकवास है। अरे भाई आपका शुगर क्या था, और ये पर्सन जो 350 में जा रही है, कितना भी एक्सरसाइज कर ले, दुनिया की सारी एक्सरसाइज अगर ये कर लेना, तो भी इनका शुगर 350 से कंट्रोल में नहीं आने वाला है। तो यू नीड टू अंडरस्टैंड that exercise is very crucial, very important, but it does not mean that it is going to fix the problem independent of the illness. And same works with depression. अगर person कोई mild moderate to severe depression में जा रहा है, वो कितनी भी एक्सरसाइज, सिर्फ एक्सरसाइज कर लेगा, तो that is not going to fix the problem. He or she might need other form of intervention, whether therapy, medications और सब कुछ लगेगा। तो तो ये, और दूसरा तो इसमें ये है कि the motivation is also missing। उनको कुछ करने की वैसे ही इच्छा नहीं है, जो चीजें करके मजा आता था भाई, वेदर इट इज म्यूजिक, रीडिंग, राइटिंग, पेंटिंग, खुशी वाली चीजें करने को भी इच्छा नहीं हो रही है। ऊपर से तुम नया बोल रहे हो एक्सरसाइज, जो उनको वैसे ही कभी नहीं किया है। तो so that is not the right approach, that to force them that do this and this is going to fix. Anyways they are not motivated, anyways they don't feel like, so it really has to be balanced and understood, and person also has to be given that amount of space and that amount of initial comfort। आप दूसरी चीजें शुरू करो, माइल्ड मेडिकेशन, माइल्ड थेरेपी वगैरह, ये सब शुरू करो, उससे मोटिवेशन हो रहा है, पुश हो रहा है, देन यू स्टार्ट एक्सरसाइज। एक्सरसाइज विल हेल्प इन लॉन्ग रन ऑल्सो, इन मेंटेनिंग ऑल्सो, बट ये जरूरी नहीं कि एक्सरसाइज हर बार प्रॉब्लम फिक्स कर ही देगा। सो गोइंग टू mental health professional and understanding what is the diagnosis, what is the intensity, severity of diagnosis, and then choosing a right approach for you, whether it is lifestyle modification, whether it is counseling, therapy, or whether it is medication, दवाइयाँ, ये क्या करना है, I think doctor would be the right person to decide for you।
Yeah. So thank you, doctor, for clarifying that. And yes, the regime has to be decided by the doctor, and one cannot decide the regime for themselves. So even as we are talking of medication here, doctor, there is generally a little fear or apprehension. Let me not use the word fear because that is too extreme. There is an apprehension that people have about taking psychiatric medicines. लोगों को डर लगता है कि psychiatric related medicines अगर लेते हैं तो शायद कोई साइड इफेक्ट हो जाए, या मेडिसिन की इतनी आदत हो जाए कि फिर वो मेडिसिन के बिना रह नहीं सकते हैं। तो ये जो डर है, वुड यू आई वुड रिक्वेस्ट यू टू एड्रेस दिस एज वेल।
I think again very important and significant point what you have brought in here। इंडिया में दो चीज के बारे में सभी को कमेंट करना है, एक है क्रिकेट और दूसरा है मेंटल हेल्थ और मेंटल हेल्थ का ट्रीटमेंट। विराट कोहली बाहर एज क्यों नहीं मारना चाहिए, कैसे एज मारना चाहिए, सभी के फेसबुक पे आ गया है कि आउटसाइड दी ऑफ बॉल को विराट कोहली एज मारता है, अभी उसको क्या करना चाहिए। विराट कोहली को नहीं पता है, पूरी दुनिया को पता है, सभी को पता है। सो दे विल एडवाइज यू सेम अबाउट द मेडिसिन एंड ट्रीटमेंट। वो डॉक्टर, वो रिलेटिव के पास जाएंगे, अरे ये दवाई तो इसमें यूज होती है, ये दवाई क्यों दिया है डॉक्टर ने। केमिस्ट के पास जाएंगे तो वो ये दवाई क्यों दिया हुआ है। बहुत है, नॉट ऑल, ऑफ कोर्स बहुत सारे केमिस्ट होते हैं जो अच्छे से समझते हैं और समझाते भी हैं, लेकिन बहुत बार कभी कुछ लूज टर्मिनोलॉजी की वजह से पेशेंट शॉक में हो जाते हैं कि हमारे डॉक्टर ने दवाई लिखी और उन्होंने तो हमको इतनी गंदी नजर से देखा कि ये दवाई क्यों खा रहे हो, इतनी एज, छोटी एज है, ये दवाई क्यों खा रहे हो, ये दवाई तो ये बीमारी में दी जाती है। सिंगल मेडिसिन कैन बी यूज्ड इन वेराइटी ऑफ डिफरेंट इलनेसेस। सो जरूरी नहीं है कि ये लिखा है तो इसका मतलब इनका डायग्नोसिस ये है। सो गूगल इज नॉट द राइट प्लेस, फ्रेंड्स आर नॉट द राइट प्लेस, apart from your doctor, nobody is in right position to make you understand why the doctor is choosing XYZ medication, number one। Number two, साइकेट्री में जैसे हमने स्टार्ट में ही डिस्कस किया, 100 अलग प्रकार की बीमारियां हैं, लेकिन जो जो डिप्रेशन है इज डिफरेंट फ्रॉम लॉट ऑफ अदर इलनेसेस। डिप्रेशन की ट्रीटमेंट के लिए जो मेडिसिन हैं, दीज आर सो स्पेसिफिक nowadays that दे आर अप्रूव्ड इन स्कूल गोइंग किड्स। हम बच्चे देखते हैं जिसमें दवाइयां FDA अप्रूव्ड है, नंबर वन। तो वो जब सेफ रहेंगी तभी अप्रूव रहेंगी, ऑब्वियस है, नंबर वन। नंबर टू, बहुत बार मैं कहूंगा 7 out of 10, 8 out of 10, 9 out of 10 टाइम्स जो हम स्पेसिफिक एंटी डिप्रेसेंट देते हैं, दोज आर नॉट स्लीपिंग पिल्स. स्लीपिंग पिल्स आर बेंजोडायजेपिन. जो हम दवाई दे रहे हैं, SSRI, SNRI, ये जो दवाइयां हैं, दीज आर नॉट स्लीपिंग पिल्स. तो आदत लगने का, एडिक्शन लगने का क्वेश्चन ही नहीं है. यू डोंट नीड टू टेक दिस मेडिकेशन लाइफ लॉन्ग, and you will not get dependent on these medications for lifelong. Number 2. Number 3, ये मैक्सिमम दवाइयां जो मैं कह रहा हूँ, हमारी नई स्पेसिफिक दवाइयां, मोस्ट ऑफ देम डोंट हैव एनी मेजर इंटरेक्शंस विद योर हार्ट, लंग, लिवर, किडनी. तो दे आर कंप्लीटली सेफ ऑन योर बॉडी सिस्टम. और बहुत बार जब दूसरी मेजर इलनेसेस होती है, MS हो गया या बहुत सारी फिजिकल इलनेसेस रहती है, पर्सन इज ऑलरेडी गोइंग थ्रू फिजिकल इलनेसेस, उसमें भी हम एंटी डिप्रेसेंट देते हैं. तो तभी दे सकते हैं जब ये पर्सन कॉम्प्रोमाइज है फिजिकली, उसके बाद भी एंटी डिप्रेसेंट ले पा रहा है, क्योंकि वो सेफ है. तो मेरी किडनी खराब हो जाएगी, दवाइयां लेने से किडनी खराब हो जाती है, सब जनरलाइजेशन है. पेन किलर लॉन्ग टर्म कैन कॉज किडनी इश्यूज, लेकिन लोग जनरलाइज कर देते हैं कि एलोपैथिक दवाई ली, लॉन्ग टर्म ली, किडनी खराब. ऐसा नहीं होता है. देयर आर मेडिकेशन जिसका किडनी पे असर ही नहीं है, तो कैसे किडनी खराब होगी. तो जो जो एक्सट्रीम फियर है कि ऐसी दवाइयों से सब ये मेरी बॉडी सिस्टम पे इम्पैक्ट करेंगी, नॉट ट्रू. थर्ड, फोर्थ एंड द मोस्ट इंपॉर्टेंट पॉइंट, वी सी स्टूडेंट्स, इंजीनियर, डॉक्टर, बैंकर, लॉयर, होम मेकर, फाइनेंस पीपल, क्रिएटिव पीपल, एक्टर्स, सिंगर्स, डायरेक्टर्स, आप नाम लो, और वो ह्यूमन ही है, उनको भी इशू होते हैं, तो हमारे पास आते हैं. वी यूज दी स्पेसिफिक मेडिकेशंस एंड दे आर फुल्ली फंक्शनल. वाइल जब कोई माइल्ड मॉडरेट से जा रहा है तो वो अपना पूरा काम भी कर रहा है, वो पेशेंट भी देख रहा है, वो इंजीनियर भी है, वो आर्किटेक्ट भी है, वो क्रिएट सिंगर भी है, वो ट्रीटमेंट के साथ अपना फुल्ली फंक्शनल है. तो ये जो थॉट है कि इससे कॉग्निशन स्लो हो जाएगा, विचार कम हो जाएंगे, तुम्हारी कैपेबिलिटी कम हो जाएगी, तुम्हारी सोच समझ कम हो जाएगी, तुम जॉम्बी बन जाओगे, ये एवरीथिंग इज मिथ. If a medication is causing sedation, you go back to your doctor. It is doctor's responsibility to modify the dose, fine tune the dose, give you the dose which is suiting you and which is giving you the balance of sleep as well as the alertness. There are patients who really complains of unable to sleep. They are unable to sleep. So usme we will choose medication which will have sedation, and those are again not benzodiazepine. Benzodiazepine भी देते हैं जहाँ पे जरूर है, लेकिन बहुत बार हम देते हैं ऐसी जो 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 बेंजोडाइजेपिन नहीं है फिर भी उसमें सेडेशन है, बट दैट इज अप्रोप्रिएट मेडिकेशन फॉर दैट पेशेंट. उनको नींद भी आ रही है और फिर नेक्स्ट डे वो प्रॉपर टाइम पे सोने के वजह से फ्रेश भी है एंड अलर्ट भी है. So choosing something and fine tuning that for specific need of that patient is what the doctor and patient can do together hand in hand. ये दूसरों की सलाह से ये सब खराब होता है, तो दूसरों की सलाह इसमें नहीं लेनी है. You can definitely have your questions, go to your doctor, ask your questions, ask your doubts and get it solved. गूगल से ये सॉल्व नहीं होने वाले हैं और बाहर भी कहीं पे सॉल्व नहीं होने वाले. तो ये जो मिथ है और ये जो फेयर है, ये completely irrational है एंड बहुत वन ऑफ द मेजर हर्डल है इन पीपल अप्रोचिंग मेंटल हेल्थ प्रोफेशनल. सो ये बिल्कुल नहीं होना चाहिए.
Doctor, I'll bring in one more aspect before, and I would like you to, talk on that before we get into the question and answers. People have been typing questions, so I'm going to reserve some time for that. But I would like to bring in the aspect of counseling here, and I will give you the context. One is, of course, patient के लिए कि मुझे क्या हो गया है. One is the medication aspect of it, but I think counseling for the patients. Then if I have to bring the Indian context to it, and if say patient अगर कोई लड़की है तो पेरेंट्स का इमीडिएटली या घर वालों का होता है अभी इसका क्या होगा, इसकी तो जिंदगी बर्बाद हो गई. सो इट स्टार्ट्स फ्रॉम देयर. अगर बहू को हो गया तो मेरे बेटे की ये शी डजंट हैव, शी हैज कम अप विथ लॉट ऑफ बैड लक, मेरे बेटे की जिंदगी बर्बाद कर दी, खुद ने तो खुद की करी थी. सो देयर इज लॉट ऑफ ब्लेमिंग. आई एम व्हाट आई एम ट्राइंग टू से इज कि काफी ब्लेम्स होते हैं. अगर किसी लड़के को हो जाए तो बहुत ही इतनी सिंपथी होती है. एंड समटाइम्स आई फील टू मच सिंपथी ऑल्सो डिसेबल्स पीपल, और टू मच इट. एम्पथी इज वन थिंग कि जहाँ आप सहानुभूति करते हो, बट sympathy इतनी ज्यादा करो तो भी people start feeling disabled. So then there is another aspect here. One is the family members, the patient, the family members, and the caregivers. It could be the family members themselves or one or two people who are significant either at home or at workplace, or they have some proper caregivers. उनकी भी बहुत प्रॉब्लम होती है बिकॉज दे हैव टू डील विथ लॉट ऑफ मूड स्विंग्स. कभी कभी टैंट्रम्स हो जाते हैं, एंड देयर इज अ कंटिन्यूअस स्ट्रेस ऑफ मेकिंग थिंग्स हैपन. एंड it's not only the patient who is feeling going through all these negative emotions, but it is also the family and also the caregivers. So uh, I would like you to comment, especially the role of counseling to deal with all of these. Uh, I mean, it's an ecosystem in itself, whether it is
True,
work, home, whatever. So I would request you to, comment on
true.
this
I
aspect.
think again very very significant, very relevant and very important points. And दो different points का है. एक आप the person who's going through it and the family, two different sides, two different emotions. Person who's going through, if female and married, and then it happens to her or it happens to one of the family members after she's just married, and unfortunately कहा जाता है that she's the one who's brought this bad luck and stuff. So very unfortunate. And the same with on the other side with if it is happening on the person, it's happening with men, then के sympathy, बहुत ज़्यादा sympathy, and then sometimes that too much of excess of anything is not the right thing to do. So that can actually stop the progress, and जो एक अंदर जो एक fire required है वहाँ पे, that fire will come with right amount of empathy, right amount of counseling, right amount of family support, right amount of motivation, and right amount of therapy. इसका combination के साथ जो, क्योंकि एक तो सपोर्ट भी आ रहा है, आपको आपको एम्पैथी भी आ रही है, काउंसलिंग पे जा रहे हैं, तो आपके जो थॉट्स हैं, थॉट्स, व्हाट हैपेंस इन दीज इलनेसेस, जैसे हमने हमने इनिशियली देखा, वो डिनायल है, एंगर है, बार्गेन है, डिप्रेशन है. वो डिप्रेशन के कॉग्निटिव डिस्टॉर्शंस होते हैं कि मैं कुछ कर ही नहीं सकता हूँ. दिस इज अ कॉग्निटिव distortion that person is generalizing that I'll not be able to do anything right now. That's not a rational thought. Same that मैं ही bad luck हूँ, that is also a distortion. Everyone hates me, that is also distortion. Nobody likes me. तो ये जो irrational thoughts हैं, ये जब काउंसलिंग पे आप जा रहे हैं, तब with your therapist you can resolve these irrational thoughts and you come back to reality. reality में जो प्रॉब्लम है, आपको उतना प्रॉब्लम देखना शुरू करना है पहले. तो ठीक है, मुझे इतना वीकनेस है या इतना वीकनेस भी नहीं है, जो भी आपके प्रॉब्लम है आप उधर तक आ गए वापस, एंड ऑल दैट बबल ऑफ I am not good enough. I cannot do anything. People don't like me. They hate me. They don't love me. And I'm bad luck. ये जितने भी irrational thoughts and distortion है, वो सब आपके resolve हो, and you come back to, तो आपका आधे से ज्यादा या 70% से ज्यादा का बैगेज दूर हो गया, and then you come back to working on what is the actual problem. So यहाँ पे इसीलिए ये बहुत ज्यादा important है, बहुत ज्यादा काम कर सकता है. So बट फर्स्ट स्टेप इज फैमिली, क्योंकि शायद वो स्टेज में एनीवेज द पर्सन इज नॉट विलिंग टू गो टू मेंटल हेल्थ प्रोफेशनल. तो फैमिली का रोल वहां पे बहुत ज्यादा क्रूशल है, टू टू एम्पथाइज विद पेशेंट, टू बी देयर एज अ सपोर्ट सिस्टम. एंड फर्स्ट तो फैमिली बोलेगी कि आप जो बोल रहे हो ऐसा कुछ है ही नहीं, ऐसा कुछ सोचने की भी जरूरत नहीं है, बट फैमिली का वो नहीं सुनेंगे. And then when it is not working for few days, then taking that patient to a mental health professionals and being there alongside with the patient in the therapy. And बहुत बार फैमिली थेरेपी भी हम करते हैं. तो वहाँ that can together serve as the right approach. That's ये अपने पेशेंट के साइड से कहा, अब इसमें फैमिली के साइड से कहता हूँ. बहुत बार फैमिली बहुत सही करते जा रही है, करते जा रही है, करते जा रही है, लेकिन पेशेंट के साइड से अगर इम्प्रूवमेंट आ रहा है, नहीं आ रहा है, then they also start feeling burnout. कहीं ना कहीं उनको भी they also start going through कि ये इम्प्रूव हो रहे हैं नहीं हो रहे हैं, ये हमको क्यों ब्लेम कर रहे हैं, एंड देयर इकोसिस्टम, देयर लाइफ, देयर प्रोफेशनल, पर्सनल, सोशल लाइफ कैन ऑल्सो स्टार्ट गेटिंग इम्पैक्टेड. सो इट इज वेरी इंपॉर्टेंट टू टेक टर्न्स. अगर आप फैमिली है, आपके पास सपोर्ट सिस्टम, जॉइंट फैमिली है, बहुत लोग अवेलेबल है, तो पीपल शुड टेक टर्न्स. जॉइंट फैमिली नहीं, न्यूक्लियर फैमिली भी है तो भी यू शुड टेक टर्न्स विद द हेल्प ऑफ योर फ्रेंड्स और विद द हेल्प ऑफ योर, आप न्यूक्लियर हैं लेकिन आपकी जो एक्सटेंडेड फैमिली है कहाँ पे है, उनका सपोर्ट लेके आप यू टेक टर्न्स. इफ यू स्टार्ट, फैमिली मेक्स श्योर दैट दे स्टार्ट अगेन ब्रिंगिंग नॉर्मलसी टू देयर लाइफ. जो अब वो जैसे वो प्रोफेशनल लाइफ में ध्यान दे रहे हैं, पर्सनल लाइफ में जो चीजें उनको खुश करती थी, उनको एक रिलीफ देती थी, एक सेरोटोनिन बूस्ट देती थी, डोपामिन बूस्ट देती थी, एक्सरसाइज करके, कोई अच्छी चीज करके, एक मूवी देख के, तो दैट इज रिक्वायर्ड. वो अगर बाहर जाके एक दिन मूवी देख लिए, दैट डज नॉट मीन दैट दे डोंट लव देयर पेशेंट. That will only bring them more revived and more uh, regenerated to back be back with that patient, and उनको और ज्यादा अच्छी तरह से हेल्प करने के लिए they'll be back. So एक right balance required है कि क्या करना है, कैसे करना है, किसके साथ करना है, और कब मेंटल हेल्थ प्रोफेशनल के साथ पास जाना है.
Yeah. Thank you so much, doctor. Doctor, I'm going to start taking reading out ki chats में अभी क्या
हम्म.
है. So Dipanjan says, if a MS person has another member in family who is going through mental issues, then how do we manage this situation? So I think you have spoken about it, but if you want to add anything more.
आई थिंक जैसे कहा, दोनों का कहीं ना कहीं रिस्पॉन्सिबिलिटी, दोनों पहले तो खुद को ही लेने की कोशिश करनी है. एमएस पर्सन को भी, जैसे हमने डिस्कस किया, हाउ ही और शी कैन एक्चुअली फाइंड मीनिंग टू देयर लाइफ. विक्टर फ्रैंकल का एक वापस कोट मैं कहना चाहूंगा, मुझे एग्जैक्ट कोट तो याद नहीं है. दैट पर्सन, लाइफ कैन टेक एवरीथिंग फ्रॉम अ पर्सन, बट ही और शी विल स्टिल हैव freedom to choose और एटीट्यूड टू चूज मीनिंग टू हिज और हर लाइफ. मेरे
Life.
वर्ड्स करेक्ट नहीं है,
Yes.
मैं आपको सिर्फ उसका थीम कह रहा हूँ कि वो, उनका एटीट्यूड जो है वो कभी भी नहीं लिया जा सकता है, कितना भी बड़ा एडवर्सिटी हो लाइफ में. एटीट्यूड इज समथिंग विच विल बी स्टिल विद द पर्सन टू मेक हिज और हर लाइफ. तो जो वो है, दिस इज वन फॉर्म ऑफ लोगोथेरेपी. ऐसे ही दूसरी बहुत सारी थेरेपीज हैं, उनके हेल्प से यू मेक श्योर दैट यू आर ट्राइंग टू बी मोस्ट rational and appropriate and fighting back with your problem. दोनों को खुद खुद का रिस्पॉन्सिबिलिटी लेना है, जितना ले सकते हैं. नहीं ले सकते हैं तो देन इट इज रोल ऑफ द अदर फैमिली मेंबर्स टू हेल्प देम डू दैट with without mental health support or with mental health support wherever required. Yes.
Yeah, that reminds me of one definition, doctor, which I would use in my development sessions with my people. वो हम लोग fear का definition ये बोलते थे कि false evidence appearing real, FEAR, and
Right.
that happens. That is true even with um, any situation that we face. Where, for example, abhi let's talk of MS or depression. So we try to make a mountain of a mole, because हर एक चीज होती है बाबा, इतना बड़ा कुछ हो गया, इतना बड़ा कुछ हो गया. So whether it is medication, तो उसके side effects बाबा इतने इतने हैं. I'm not able to do this, I'm not able to do that. But rationalizing those thoughts, because it's a false evidence that is appearing so real, and that too in a magnified way. So I think the first step would be to reduce it. वो जो immediately जो इतना बड़ा दिखता है, मैग्निफाइड दिखता है, उसका
True.
रिडक्शन करते जाना चाहिए. एंड आई थिंक दैट्स वेयर द डॉक्टर्स role is very important, and the doctors can help patients to help them see what the
True.
real reality is and not what the false reality is.
Very true, very true. I think this to an extent goes with के पर्सन, मतलब ऐसा नहीं है डिप्रेशन, डिप्रेशन बहुत लोगों को एंजाइटी भी होती है, एंड दिस गोज विद एंजाइटी. एंजाइटी में
Yes.
प्राइमरी कोर सिम्टम क्या है, इज ऑलवेज फियर ऑफ समथिंग विच इज नॉट रियल. सो एंटिसिपेटिंग, ये हो जाएगा, ये हो जाएगा, ऐसे हो जाएगा, ऐसे हो जाएगा, ऐसे हो जाएगा. सो जो है भी नहीं आज के दिन पे, आज का दिन क्या है, 11th of January, आज के दिन पे अभी कुछ इतना गड़बड़ नहीं है, लेकिन इन देयर माइंड दे आर थिंकिंग ये ऐसे हो जाएगा, 6 महीने में इतना खराब हो जाएगा, 1 साल में इतना खराब हो जाएगा, आगे का पूरा लाइफ इतना खराब हो जाएगा, प्रोफेशनल में ये मेरा जॉब छूट जाएगा, पर्सनल लाइफ में ये हो जाएगा, आई विल नॉट बी एबल टू डू एनीथिंग, फैमिली विल नॉट डू एनीथिंग, फाइनेंशियल लॉस हो जाए। ये थॉट तो चल रहा है, वो थॉट वो बिलीव करने लग जाते हैं, एंड देन दे स्टार्ट फीलिंग इट राइट नाउ। तो आज के दिन में मैं ऑलरेडी फील कर रहा हूँ मेरा जॉब चले गया है, मेरी फैमिली चले गई है, मेरा ये हो गया, देन दैट brings इन दैट intensity of sadness and depression then kicks in. So जो rationalization है, उस पर्सन को वी ब्रिंग बैक टू प्रेजेंट, कि प्रेजेंट में क्या है, प्रेजेंट में इसमें से कुछ भी हो रहा है, नहीं हो रहा है, आप वो सोच रहे थे, हाँ सोच रहा था वो। सो क्लासिकल characteristics, core characteristics of anxieties, it brings you, it takes you to future, and future anticipation of negative thoughts. You need to realize कि बहुत बार मेरे को एंजाइटी की वजह से थॉट आने वाला है, थॉट शायद मेरे हाथ में नहीं है, लेकिन कितना थॉट को मैं बिलीव करूँ और उसको मैं कितना वेटेज दूँ, दैट इज गोइंग टू डिसाइड कि मैं उस पर कितना रिएक्ट कर रहा हूँ। यही उल्टा थॉट है कि मैं आपको बोलूँ आज के अभी के अभी कि आपको 100 crores मिलने वाले हैं, तो उस पे आप कितना बिलीव करेंगे, आप उसको वेटेज ही नहीं देंगे, एंड दैट बिकॉज यू डोंट गिव वेटेज, यू डोंट फील इट, इट डज नॉट कम इन,
Yeah,
राइट?
very
सो
true. Yeah.
सो
So I'll go ahead. So, someone is saying that I'm diagnosed in 2004. Environmental factors like layoff in office, death of a friend, etc., gives depression caused by prolonged bad mood. Usually, good music snaps me to good mood. Some medicines for MS give bad mood and make me irritable. Open talk with primary neurologist helps. So this is what the person has written.
हाँ, मतलब शॉर्ट में अच्छे
Yeah.
से समराइज किया है कि बहुत बार there are things which are helping that person, whether it is music, whether it is exercise, whether it is yoga, whether it is meditation. हमने मेडिटेशन के बारे में बहुत बात नहीं किया, लेकिन बहुत वन ऑफ द मोस्ट अंडररेटेड एंड मोस्ट इंपॉर्टेंट थिंग अगर मैं आपको रेकमेंड करूंगा तो वो होगा एक्सरसाइज एंड मेडिटेशन। मेडिटेशन इज समथिंग विच ब्रिंग्स यू इन प्रेजेंट, माइंडफुलनेस मेरे को प्रेजेंट में लेके आता है, प्रेजेंट में लेके आ जाते हो, ऑटोमेटिकली मेरे जो एंटिसिपेटरी थॉट्स हैं वो कम हो जाते हैं, एंड जो मेरी फ्रीक्वेंसी ऑफ थॉट्स है वो ऑटोमेटिकली इंटेंसिटी ऑफ थॉट्स कम हो जाती है, मेरा कॉन्सेंट्रेशन इंप्रूव होता है, तो ऑटोमेटिकली आई एम बेटर इन प्रेजेंट, मूड इंप्रूव होता है, कंसंट्रेशन इंप्रूव होता है। तो बहुत सारे सिम्टम्स, जिनको एमएस है उनको भी, एमएस नहीं है उनको भी मेडिटेशन 200% रिकमेंडेड। सो देन इन ये केस में म्यूजिक हेल्प कर रहा है उनको, टॉकिंग टू न्यूरोलॉजिस्ट, सो बेसिकली वेंटिंग आउट समटाइम्स हेल्प। सो वेंटिंग आउट कैन हैपन विद क्लोज फ्रेंड्स, कैन happen with family members, and can help with mental health professionals. So find out these things which are helping you, whether it is music, whether it is exercise, meditation, Zumba, badminton, squash, cricket, talking to family, talking to friends, eating good, sleeping good, avoiding substance. बहुत सारी जेनरिक चीजें, बट बिलीव मी ये जेनरिक चीजें अगर आप कर रहे हैं 70-80% ऑफ द टाइम इट इज डेफिनेटली गोइंग टू हेल्प यू।
Yeah. So Devraj Krishnan wants to know depression medication, what could be reactions? So maybe reactions or side effects is what he's meaning.
जैसे मैंने आपको कहा, न्यूअर एंटी डिप्रेसेंट्स आर वेरी स्पेसिफिक, मोस्ट ऑफ देम हैव नो इंटरेक्शन विद एमएस मेडिकेशंस, सो बोथ द ट्रीटमेंट कैन साइमल्टेनियसली हैपन। अब एमएस की भी ट्रीटमेंट अगर है, आपको मेडिकेशंस एडवाइज्ड हैं, तो यू कैन टेक दोज मेडिकेशंस एंड यू कैन टेक एंटी डिप्रेसेंट विद द एडवाइस ऑफ योर डॉक्टर्स, एंड मोस्ट ऑफ देम विल नॉट हैव एन इंटरेक्शंस अमॉन्ग्स देम। रहा मेडिकेशन का छोटा मोटा साइड इफेक्ट, तो बहुत सारे पेशेंट में होता ही नहीं है, आपको कुछ हो रहा है specific to you, you go and speak to your doctors, but more or less आप most of the cases में no interaction, no side effects, very specific, you can take it with the advice of your doctor.
The next question is, please talk about OCD.
तो OCD, आई थिंक जैसे वी ऑलरेडी डिस्कस, OCD मतलब एंजाइटी स्पेक्ट्रम में आ जाता है। तो एंजाइटी स्पेक्ट्रम में OCD, एंजाइटी, जनरलाइज एंजाइटी, सोशल एंजाइटी, पैनिक डिसऑर्डर, फोबिया, PTSD सब कुछ आता है। तो OCD, basically, person going through OCD, unko, they could have one or the other different obsession, whether it is washing their hands frequently, whether it is checking few things again and again, keeping things in order, or sometimes praying too much, sometimes related to some numbers or doing activities in certain way. So uh, it is something which again can really improve with medication as well as therapy. Medication से उनकी anxiety and compulsion, OCD का मतलब primary core क्या है? It starts with a obsessive thought के मुझे ये मैंने यहाँ पे टच कर लिया तो यहाँ पे जर्म्स है और मेरे हाथ पे जर्म्स लग जाएगा, मुझे कुछ हो जाएगा, बीमारी, इसके लिए वो जाके रिपीटेडली धो रहे हैं. सो दैट्स अ ऑब्सेसिव थॉट. एंड जो ओसीडी थॉट रहता है वो हमेशा 100 आउट ऑफ 100 टाइम्स इरेशनल होता है. मतलब यहाँ पे ही मैं बैठा हूँ, यहाँ पे कोई ऐसे हाथ लगाने से जर्म्स होने की लॉजिक कुछ नहीं है, बट स्टिल दे विल हैव दैट थॉट, and that thought will create anxiety, and anxiety will lead to compulsion of washing their hands. So medications की वजह से क्या होता है, एंजाइटी कम हो जाती है, इसके लिए कंपल्शन कम हो जाते हैं, वॉशिंग ही कम हो गया, तो सिर्फ ऑब्सेसिव थॉट बचा. तो बचा वो ऑब्सेसिव थॉट को आप थेरेपी से कि कैसे उसको डील करना है, क्या करना है, दैट कैन रियली गो विथ sometimes medication only, sometimes medication plus therapy. So can happen along with MS sometimes and can be treated in the same way by going to your mental health professionals and deciding whether it is only medication or medication plus therapy.
Yeah. The next one, I think we have touched upon it. Though I'm reading it out, Bharat says most of us have a family doctor called Google, said by caretakers. What can
Hmm.
be done? So we
Hmm.
spoke about it. Like you said, we can't rely on Google. Only doctor, when he meets you or the doctor meets you, is when they can tell you what is right for you.
See, एक बहुत इसमें मैं ऐड करना चाहूंगा, ऐसा नहीं है कि गूगल पे जो इन्फॉर्मेशन दिया वो सही नहीं है, लेकिन उन्होंने एक पैराग्राफ पढ़ के आप उसके 50 पेज आगे 50 पेज पीछे का इतना बड़ा चैप्टर है, वो आप पढ़ नहीं रहे हैं. तो एक इन्फॉर्मेशन मैं पढ़ के मैं उस पे से सही कंक्लूजन पे नहीं आ पाऊंगा, इसके लिए गूगल पे नहीं पढ़ना है. एंड एनीवेज आई एम इन दैट जोन ऑफ fear, negativity, डर, hopelessness, and that information मैं कैसे perceive करूंगा versus some other person who's not going through that phase versus doctor who's been trained in that. वो तीनों भी ये पैराग्राफ पढ़ेंगे, तीनों का perception about that paragraph would be different, and that is why you should not be on Google. And Google की वजह से 50%, एटलीस्ट 50% पेशेंट की एंजाइटी, फियर, थॉट्स, डर, ये हो जाएगा, ये हो जाएगा, ये हो जाएगा, बढ़ जाता है. मिनिमम 50% कह रहा हूँ मैं, उससे ज्यादा ही है. इसीलिए गूगल इज 10 आउट ऑफ 10 टाइम्स नॉट रिकमेंडेड. आपको क्वेश्चंस हो सकते हैं, आप क्वेश्चंस जाके डॉक्टर से पूछिए. आप वो क्वेश्चन जब उस पर टाइप करेंगे, उस पर जो इन्फॉर्मेशन आ रहा है उसको आप परसीव ही सही तरह से नहीं कर रहे हैं. आप हेडेक डालेंगे तो तीसरा ऑप्शन ट्यूमर आएगा. आपको बचपन से कितनी बार हेडेक हुआ और कितनी बार आपको ट्यूमर डायग्नोस हुआ है, तो ट्यूमर जो डायग्नोसिस उस पे आया है वो गलत नहीं है, लेकिन मैं कह रहा हूँ ना, उसको जैसे आपको परसीव करना है वो बहुत मैटर करता है. दैट इज व्हाई इट इज नॉट रिकमेंडेड एंड नॉट एडवाइज्ड.
Yeah, there is a difference. Google will give you one paragraph, but the doctor comes with a life experience and life's training. And so the doctor is in a is the only person who can actually diagnose and treat you and not Google.
एंड दिस इज एप्लीकेबल टू एवरी फील्ड. मैं ये नहीं कह रहा हूँ मैं डॉक्टर हूँ
No,
मुझे
no,
सब
here
ज्यादा
we are
पता है.
talking of
एवरी
medicine. That is
फील्ड.
why. Yeah.
यस, नो नो, ये
You
दूसरी
cannot build
फील्ड
a
में भी
building, for
एप्लीकेबल है.
example. Google में पढ़
यस,
के मैं building नहीं बांध सकती हूँ.
परफेक्ट परफेक्ट, एकदम परफेक्ट कहा. सेम में मेरे को मेरी फाइनेंशियल एडवाइस लेनी है, वो जो मेरे को मेरा फाइनेंशियल एडवाइजर देगा वो गूगल पे अवेलेबल है, बट मैं वो पढ़ के उतना वो जो कर रहा है वैसे कर पाऊंगा, नहीं कर पाऊंगा. तो इट इज एप्लीकेबल टू एवरी फील्ड. और
Yeah.
हमारी फील्ड में ज्यादा मैटर क्यों कर रहा है? इट इज अबाउट लाइफ. आपकी लाइफ और कैसे जिंदगी जी रहे हैं उस पर डिपेंड कर रहा है. इसके लिए इस पे तो आप चांस ही नहीं ले सकते.
Yeah. Some of our participants today have said that they have liked the session. So thank you, doctor. Thank you very much. And thank you for the
थैंक यू सो
compliments
मच.
as well. The next is toxic positivity is trigger for irritability that is capable of long-term depression or overthinking. So that's from Raghuram.
राइट।
I-
टॉक्सिक पॉजिटिविटी का मतलब शायद मुझे लगता है ये कहना चाहते हैं कि बहुत बार जैसे टॉक्सिक पॉजिटिविटी कहा ना आपने।
हाँ।
हाँ, तो पर्सन डिप्रेशन से जा रहा है, शायद मैं जितना समझ रहा हूँ वो ये कहना चाहते हैं। तो एंड बहुत बार फैमिली मेंबर्स या फ्रेंड्स या जो भी उनको पुश कर रहे हैं, तो वो पुश करते वक्त हमको बैलेंस भी करना है कि कैसे पुश करना है, कितना पुश करना है। वो बोलेंगे तुम सोचो ही मत, तुम अभी के अभी एक्सरसाइज करो, ये हो जाएगा, ये हो जाएगा, हो जाएगा, अभी कभी एक्सरसाइज करो, तुम सोचो ही मत, तुम उदास हो ऐसे सोचो ही मत। तो एक ही चीज हर एक, मैं कह रहा हूँ ना, कौन से स्टेज में और कौन से माइंडसेट में है, कब है, कैसे है, उस पे भी डिपेंड करता है। यही चीज किसी के लिए काम करेगी और उनके लिए बहुत परफेक्ट काम करेगी और किसी के लिए नहीं करेगी। वो डिफरेंस बहुत ज्यादा जरूरी है। हाँ, आप एक बड़े पेड़ को जितना पानी दोगे और एक नए सीड को जितना पानी दोगे सेम नहीं हो सकता है, दोनों को ही ग्रो करना है, राइट। तो तो इट हैज टू बी अप्रोप्रिएट, कब करना है, कैसे करना है और कितना करना है और कितना उनको सपोर्ट के साथ उनको स्पेस भी देना है। दोनों जब बैलेंस में जाते हैं तो 100% हेल्प करता है और काम करता है। पॉजिटिविटी तो अच्छी ही है, होनी ही चाहिए, बट वो बैलेंस के साथ होनी चाहिए।
So, Nilesh writes, thank you for the session. It's very helpful. I have two questions. Does anxiety, depression, is it caused only due to tough circumstances and traumatic memories from past, or there are any genetic reasons as well? And second question is, how can we prevent depression from happening in the first place? And asking this because, as you said, most people deny the fact that it can happen to them and lose out on the opportunity of taking the preventive measures.
यस, तो जेनेटिक तो डेफिनेटली होता ही है। पर्सन जिनके फैमिली में डिप्रेशन का हिस्ट्री है या कोई भी मेंटल हेल्थ इशू का हिस्ट्री है, एवरेज पॉपुलेशन की प्रोबेबिलिटी अगर वन, लेट्स से आप 2 to 3 आउट ऑफ 100 है डिप्रेशन होने की, तो जो पर्सन विद फैमिली मेंबर में वो 4 to 5 या 4 to 6 हो जाएगी होने की। तो जेनेटिक का मतलब यही है कि चांसेस ऑफ यू हैविंग depression or any other mental health issue increases slightly if you have a family member who's already going through it, number one. Number two, then the treatment जो उनमें काम किया है वो आप में काम करने की probability बढ़ जाती है। number three is, अगर, तो इसका मतलब ये नहीं कि उनको है तो हमको होगा ही, but then if it is already there then you need to be more cautious। मेरे फैमिली में अगर डायबिटीज है तो then I'm more cautious, right, I'm more aware कि मुझे क्या क्या चीजें सही करनी है। तो हम सभी के लिए मैंने जनरली हर सेशन में कहता हूँ, इस सेशन में भी कहूंगा, 7 चीजें हैं जो मैं कहूंगा हम सभी को करनी चाहिए, इंडिपेंडेंट ऑफ डिप्रेशन है नहीं है, आएगा नहीं आएगा। अगर हम ये 7 चीजें कर रहे हैं तो देन चांसेस ऑफ यू फाइटिंग एनी मेंटल हेल्थ इश्यूज आर मच ब्राइटर। नंबर वन इज एडिक्वेट स्लीप। आपकी नींद अच्छी हो, एक क्वालिटेटिवली 6 to 8 आवर्स के बीच में राइट टाइम पे होनी चाहिए। यू शुड बी स्लीपिंग बाय 10, 11, मैक्सिमम 12, एंड यू शुड बी गेटिंग अप बाय 6, 7, 8। तो वो एक राइट टाइम पे स्लीप एंड एडिक्वेट स्लीप हुई। सो एडिक्वेट स्लीप, हेल्दी डाइट, फ्रूट्स, ग्रीन वेजिटेबल, ड्राई फ्रूट, मिल्क। आई एम वेजिटेरियन तो मैं वेजिटेरियन को ही प्रमोट करूंगा कि वेजिटेरियन खाओ, अच्छा खाओ, हेल्दी खाओ। जंक फूड ऑफ कोर्स आप खा सकते हैं, लेकिन इट हैज टू बी बैलेंस्ड। आप हफ्ते में 1 बार खाओ, 2 बार खाओ, उससे ज्यादा खाएंगे तो कहीं ना कहीं वो थोड़ा इम्पैक्ट करेगा। डिप्रेशन नहीं लाएगा बट कहीं ना कहीं इम्पैक्ट करेगा। सो एडिक्वेट एंड हेल्दी फूड। नंबर थ्री इज एक्सरसाइज। एक्सरसाइज, जैसे क्रांति जी ने कहा, इट हेल्प्ड हर, एंड आई नो मेनी 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 पीपल who have really come out of their struggles because of exercise. So it can be in any form. It can be gym, swimming, yoga, zumba, badminton, squash, cricket। आप जाओ, मॉर्निंग में आप खेलते हो, इट ब्रिंग्स इन दैट पॉजिटिविटी, एनर्जी, डोपामिन बूस्ट, सेरोटोनिन बूस्ट, वो एक खुशी मिलती है। तो सो डू दैट, नंबर थ्री। नंबर एंड मॉर्निंग में विटामिन डी मिलता है जो बहुत क्रूशियल है। मोस्ट ऑफ अस आर डेफिशिएंट इन दैट। नंबर फोर is meditation. Meditation brings you in present, reduces thoughts, reduces negativity, helps you improve focus, helps your concentration, helps you be more productive, more active, and more uh, mindful in whatever you're doing. So fourth is mindful. Fifth is talking to your friends and family. One again बहुत ज्यादा एक important चीज जो थोड़ी सी underrated है कि आप बहुत बार हम दोस्तों के साथ बैठते हैं और ऐसे ही चिट चैट करते रहते हैं, और वो जो ऑर्गेनिकली हमारी चीजें वेंट आउट हो जाती है ना, इट इज कहीं ना कहीं थेरेपी. So that is required. Be in touch with your close friends who don't judge you, and you can open up your heart there. तो ये सब चीजें डेली में जब है, तो कहीं ना कहीं वो आपको वो बिल्टअप ही नहीं होने देती हैं, आप वो आपको वो बेसलाइन लेवल पे ही हेल्प करते जाती है. टॉकिंग टू फ्रेंड्स एंड फैमिली इज फिफ्थ. Sixth is a personal hobby. It could be anything. It could be music, it could be reading, it could be writing, it could be painting, it could be anything. वीकडेज पे बहुत मुश्किल हो जाता है टाइम करने को. वीकेंड्स पे आधा घंटा, एक घंटा, 2 घंटा, या वीकडेज पे भी आधा घंटा. If you're doing that, that can really bring in that joy and happiness. So being in touch with your hobby, your passion, apart from your work, is sixth. And seventh and last is altruism. Altruism is doing something for someone else. ये जो एक आपका सेल्फ वर्थ बढ़ाएगा ना, आपने किसी और के लिए कुछ एक छोटी सी भी चीज की जो कहीं पे भी इसके लिए नहीं की है कि इसकी वजह से आपको कुछ ना कुछ वापस मिलने वाला है, मटेरियलिस्टिक, नॉन मटेरियलिस्टिक, बिना कोई एक्सपेक्टेशन की, जब आप किसी के लिए कुछ करते हैं, ये जो आपका सेल्फ वर्थ बढ़ाता है ना, दुनिया की कोई चीज नहीं बढ़ा सकती. सो फाइंडिंग अपॉर्चुनिटीज टू बी दैट altruistic person is can be game changer.
Yeah. Doctor, you have answered some of the questions that are there further, so I'm just going to read
Kranti,
those.
Kranti, Dr. Neeraj has joined.
Yeah, yeah.
So,
I'm going to
we
take
will,
5-7 minutes more
yeah,
before I close with Dr.
yeah,
Shyam.
yeah.
Yeah. Dr. Neeraj, welcome to the meeting. I'll just take another 7 minutes before, I come back to you.
Yeah, that's fine with me. Thank you.
Yeah, thank you so much.
Hi, Dr. Neeraj, how are you doing?
I think
I think
he's
he's
on
on mute.
mute.
Yeah.
Yeah, so Dr. Shyam, quickly I'll go through. Someone has mentioned that, gray clouds, rain increases depression for the person, and you have surely talked of various ways of, how to deal with depression. So, this is one of the triggers of the person. Another person has asked, how do you improve serotonin apart from exercise? Your last, all the 5 or 6 points that you spoke were necessarily about improving your serotonin, all the ways that you spoke just now. I'm not the will yoga help? We have spoken about exercise. We have spoken of meditation as well. What would you say about pets helping with depression? So I think again, pets, according to me, like you said, friends and family and people with whom you are happy, altruism that you spoke of, I think pets fall into all those categories. So I think they should help.
Pets, उसमें मैं pets भूल गया. 200%
Yeah.
recommended. There are therapy dogs and all form of pets, but especially dogs. There are therapy dogs. And वहां से जो एक आपको unconditional प्यार मिलता है can really help a lot of people.
Yeah.
जो एक loneliness है, emptiness है, वो कम करने के लिए.
Correct. So one of the questions Charu asks is, what about ADHD and MS? So can we allude to what you spoke about OCD here? The measures.
Not exactly. OCD वाली चीजें ठीक है, थोड़ा अलग हो गया. ADHD जैसे MS
ADHD is
is
different, yeah.
ADHD, because MS itself is a central nervous system disease, it can really hamper concentration. So either again depending on the intensity and severity, if the intensity is mild and person को MS से पहले ADHD नहीं था, तो approach would be slightly different. So basically deciding how intense and how severe are the symptoms, whether to go for lifestyle modification, yoga, meditation is something which can really help with focus and mild ADD or ADHD. And if it is severe, then of course doing these things plus adding medications, pills to improve focus. Those would be temporary.
Yeah. Um, We can communicate it to take Google. I'll take what was not spoken about earlier. Okay, I'll just read quickly. I do not have black patches occurred on my ears, and it has gone now. Should I take non-psychiatric questions here? I'm not sure. Doctor?
कुछ भी पूछो, मुझे आता रहेगा उतना मैं बता दूंगा, कोई
बता
इश्यू नहीं
देंगे
है.
आप? Okay, एक minute. I'll just read it out. I do have black patches occurred on the ears, and it has gone now after 3 months. But many of our parents think we might not be taking proper bath or face wash. How can it be communicated that it is the symptoms, not carelessness? I had done family detachment due to this, but the question is, will that be right way to do that?
नहीं, आई थिंक बहुत ही वेग क्वेश्चन है, कहीं ना कहीं हम मिस कर रहे हैं.
Yeah,
I-
so maybe we'll have to take it sometime
yes,
later.
yes.
Exercise is good. Yeah. Physiotherapy also is someone, that, what about physiotherapy to manage fatigue, etc. And how do you manage noise sensitivity?
आई थिंक वेरी इम्पोर्टेंट. जितना जितना थेरेपी, whether it is psychological therapies, different form of, उतना ही physiotherapy कहीं ना कहीं important है to regain your strength and to regain that muscle strength and muscle mass. So very crucial, very important. And noise sensitivity क्यों हो रही है? Is it because of MS or is it because of depression की वजह से भी चिड़चिड़ापन हो रहा है? So identifying and then addressing it would be the right approach.
Thank you, doctor. You have been really patient with us with all our questions, and you have talked on depression in detail in a wonderful manner. I'm sure it has, as it has helped me, it has helped everyone on the group here. And if you don't mind, I would say that on behalf of you and I would like to make a statement that let us understand that depression is not a permanent state. It can be dealt with a proper approach, proper therapy, with the help of your doctor. So
Absolutely, absolutely, 200%. I think 9 out of 10 times depression is a temporary illness which is completely treatable. So I completely agree to you.
yeah, thank you so much, doctor. Thank you for being with us. MSSI thanks you from the bottom of our hearts. Thank you so much.
Thank you so much. Thank you so much,
Thank
Thank
you
you,
Kranti
very
Dr.
ji.
much.
Shyam.
Thank you
Thank
so
you,
And
much,
nice
Dr.
Sheila
Shyam.
talking to
ji.
you.
Keep your
कभी
blessings
भी
on
मैं
us.
बुलाती हूँ, आप आ गए, मुझे बहुत बहुत खुशी हो गई. Very, very
My
happy.
pleasure, my
Thank you.
pleasure, my pleasure. Thank you so
Thank
much.
Yes,
See you
thank you
soon.
so much.
Bye.
Bye. Have a good day. Bye.
Bye, bye. Take care.
Bye, Dr. Shyam.
Bye, Dr. Neeraj.
Bye.
Bye.
Hope to see you sometime. Thank you.
Yeah, yeah, absolutely. Bye. See you soon.
Yeah, bye.
Dr. Neeraj, namaskar.
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 Hello. Good morning, Dr. Jain.
Good morning.
Yeah, just for I had introduced myself at the start of the session this morning, but I would like to introduce myself to you. I'm Kranti Munje, and I am the honorary secretary for MSSI Mumbai chapter. I'm an MS patient as well for close to 16 years now. So
Right.
I am talking and hosting this session in two capacities. One as a MSP, and second as the secretary of the MS Society of India Mumbai chapter. So on behalf of MSSI and also all the participants that we have in this meeting here today, I would like to welcome you formally to this session. And I would like to also introduce you to everyone. Dr. Neeraj Jain for the MS Society needs no introduction. He's been there for us all the time. We have, Mrs. Sheila Chitnis is so much in touch with him, and he helps us out all the while. So formal introduction is he's MD, DNB medicine and neurology, internal medicine. He has one moment. Just reading it out. His DNB Neurology, Fellowship Neuromuscular Diseases Institute de Myologie, Paris. Professor and Head Department of Neurology, Shet GS Medical College and KM Hospital, Mumbai. He is consultant neurologist with Apollo Hospital, Navi, Mumbai. His his fields of interest are epilepsy, Comprehensive Epilepsy Care Center, KEM Hospital, Mumbai, EEG, and neuromuscular diseases. He has 20 international publications to his credit, 10 national and 6 posters to his credit, and his achievements and awards: traveling fellowship bursary for AOMC 2009 Seoul. So we have a eminent doctor with us today, and he's the best person to talk to us about all the newest therapies that we have available to choose from today. So welcome, doctor, to the session, and over to you.
Thank you very much, Ms. Kranti and Mrs. Sheila Chitnis for inviting me for this talk. So my talk will be mainly concentrating on the management of the multiple sclerosis and the drugs which are available off late in Indian market. And there would be, obviously, because it is drugs, so there would be some scientific content in it. It cannot be only the medical aspect. I'll share my presentation now. Are you able to see it?
Yes.
Is it visible?
Yes.
Visible.
Yes.
Okay. So, though the topic given is newer treatment, but I will be discussing about the available treatments for MS because the time is not short. So, as we are aware that India, the diagnosis of multiple sclerosis is easily done nowadays because of the availability of the neurologist even in the tehsil places, district places, and even in the good quality MRIs are available in every corner of India. So definitely we are picking up much more MS patients than what we used to do around 10 to 15 years back. There are some MS multiple sclerosis variants also which are common in Asian population like neuromyelitis optica and MOG disease, which mimic like MS but which are not MS. So now we are more confident with the available investigations about the diagnosis as well as the treatment. So today we'll be concentrating mainly about the multiple sclerosis, though it is one of the demyelinating disease which affects the population, but then MS is the main which is very common. So as we are aware that it is a chronic disease and basically inflammation and demyelination in the central nervous system. So central nervous system comprises of the brain and spinal cord and optic nerve also, because the optic nerve is supposed to be a continuation of the brain. So demyelination is basically, in layman's term, it is the covering of the neurons which get damaged, and eventually the demyelination leads to axonal damage. So initially the covering get damaged, but later on as the disease progresses, the axon itself, the cylinder itself get damaged. It is more common in women than men, and the age of onset is 20 to 40 years usually. But there are pediatric MS patients as well as there are some patients who are diagnosed after age of 40. So whenever we talk about any treatment, I'm just discussing because from the treatment perspective, it is important for these terms to be known. So what is a relapse? So when we already have diagnosed that some person is multiple sclerosis by doing all sort of tests, then the person comes with some symptoms. So whether it is a relapse or whether it is a symptom which is old, that we need to distinguish. So relapse word is very important, whether really it is a new thing which has come in the phase of MS. So a relapse is a monophasic clinical episode with patient reports as symptoms and objective findings which are typical of MS, which reflect some damage in the CNS. It can develop acutely or subacutely with the duration of 24 hours. So a new symptom in a known case of multiple sclerosis that needs to be reported by the patient, and simultaneously the doctor analyzes those symptoms, whether this is non-specific symptom or it can be a specific symptom pertaining to MS, and whether this will fit into the relapse category, because the number of relapses or the type of relapse is what determines our course of action from the management perspective. The other thing is in absence of fever or infection, because a person who has MS, who has underlying disease, in presence of fever or any infection can get increase in symptoms. but it may not be a new attack. It may not be a new damage in the brain. So we need to distinguish by doing certain tests or by examining the patient whether it is really a new relapse. These are general clinical features which most of the patients are aware, but then just to point out that person can have sensory loss, means numbness on one side or tingling on one side, optic neuritis, that is the vision problem, weakness, sudden weakness in the limbs, paresthesia, that is the tingling, burning sensation, double vision, imbalance, vertigo, paroxysmal attacks, that means that sudden increase in the pain or sudden increase in the sensory symptoms, bladder complaint, difficulty in controlling bladder. Then one symptom I have written, it is, though it is a medical term, Larimer's phenomenon. So many patients who have a problem in the cervical spine, when they bend their neck, they get electric shock-like sensation traveling over the body. So that is one symptom. Pain is one of the symptom in multiple sclerosis. But then pain, if it is chronic pain, then you don't call it as a relapse. So you need to analyze each symptom, report to the treating doctor, and then they will analyze, and depending on the situation, if it is a new relapse, then definitely the therapies would be considered. Facial palsy, impotence, epilepsy, which is rare. Epilepsy and dementia usually are rare. Dementia happens in very rare percentage of patients who are uncontrolled, untreated, and that also in long term. Then some ancillary symptoms, means these are not new relapse, but heat sensitivity, paroxysmal symptom, trigeminal neuralgia, facial myokemia. Facial myokemia is the twitchings on the facial muscles. So these are ancillary symptoms, but they may not qualify for the relapse. So as we are aware, whenever we discuss about the treatment, we need to classify a person on the criteria, what particular subtype of MS it is, whether it is relapsing remitting multiple sclerosis, whether it is clinically isolated syndrome, secondary progressive or primary progressive. These terminologies are important from the management perspective and also from the prognosis. So there can be a variety. So many times we have a preclinical, this we are discussing about the longitudinal progression of a person. So initially there are preclinical symptoms which may not be non-specific, then person is diagnosed with MS. So person can have relapses. So sudden increase in the symptoms, then again relapse, then again relapse. So this is called as relapsing remitting MS. So the patient has relapsed, with treatment it improves. Again relapse, then it improves. And then after certain years, if untreated or if not properly treated or if their drugs are not effective, then some people can go into secondary progressive MS. The MRI lesions increase over a period of time in most of the patients with the natural course, and usually the brain volume decreases. Now, these are two terminologies which many times you might have read on the diagnosis of. So if person who presents with an event that is clinically means we feel that the symptoms can be in MS, but then it does not meet the criteria for multiple sclerosis as of now. So we have certain set of criteria. Whenever we label MS, it is not that just you walk in and you label MS. There are certain set of tests. There are certain set of clinical criteria which need to be there in that person. So this clinical isolated syndrome is a person has MS-like features, but at present you cannot qualify to be full-blown relapsing remitting multiple sclerosis. And then there is a term called as radiographically isolated syndrome, in which you have the MRI features, but not all the clinical features. MRI is abnormal, but then you don't have that all the features. So I won't be going into detail, but the diagnosis of multiple sclerosis requires dissemination in space and time. Space means in MRI, the space, so the multiple locations of the brain. Time means one attack has happened today and one attack in the later date. So this that's why history is important. Whenever you visit a neurologist, he will ask whether in past you have any history of vision loss or sudden weakness on one side. Why it is important? Because you may have a symptom reported today, but then you might have some symptom which would inform us that some relapse might have happened in past. And with MRI, we can confirm it. So there are certain set of tests which are done, especially MRI, CSF, and then this is the standard criteria what we follow for the diagnosis of multiple sclerosis. This is called as McDonald's criteria. Then I won't go into detail. MRI lesions. So there are typical locations of the lesions on the MRI, and depending on the so these are the classical lesions of the MS, which involve the periventricular and corpus callosum locations. Then there are multiple white patches which are seen. So all patients may not have the typical picture. Some patients would have qualification on the CSF and plus MRI, but some patients can have clinically only we diagnose with MS and just rule out certain other diseases which mimic multiple sclerosis. So now coming on the treatment, this understanding was important because whenever you give any treatment, so the subtype of MS is important. If somebody has primary progressive MS, then the treatment options would be different. If somebody has RRMS, that is relapsing remitting, then the treatment option would be different. So that's why the basic understanding is required, even from the patient perspective, but because now it is the information is easily available. So what are the goals? Once you have diagnosed that certain person has multiple sclerosis, so what is what we feel, what is the goal? The goal is to treat the acute relapse, to shorten the duration and remedy their residual effects. Because whenever there is optic neuritis, you need to improve the vision fast by giving some treatment and to limit the residual effects so that it doesn't leave behind some visual loss. Disease modification to reduce the frequency of relapses, relief or modification of symptoms, and the family and the patient support for the social and the economic effects, which are very, very important in multiple sclerosis because the therapies are costly, and then there are disability which can lead to loss of income. So this support system, which MSSI is doing very well, is very important for treatment purpose. So the treatment is divided into three parts. One is the whenever there is an acute problem, that is the treatment for the acute attack, then treatment with the disease modifying agent, which reduces the biological activity of the MS, then symptomatic therapy. And usually in research setting, as well as some of the MS clinics, we do follow EDSS, that is the disability score. So it is just the progression, which is basically assessed. So whenever there is an acute attack, if you go to a neurologist, they may not investigate. If it is a clear-cut clinical attack, then even MRI is not required. You just treat it with a steroid dose. It is a standard dose followed world over. And initially injectable steroid, which can be taken even on OPD basis. So many patients ask that whether they need to get admitted for this. But then steroids are safe. For the acute relapse, they can be given on the OPD basis by even a general practitioner. So this is important because if you have if you are known problem of multiple sclerosis, if you have a sudden vision problem today, and if you are not able to assess the doctor or a hospital or a neurologist, then because you are known patient with sudden problem, the treatment should be started immediately. So you can meet a local physician and start the treatment. Later on, you can take the appointment with the particular specialist. Because if you meet after 8 days, then already some visual loss has happened. So the recovery would be late. So that's why for acute attack, it is always recommended that the treatment should be started ASAP, as soon as possible. And that is a standard course of regimen. These are safe. What are the side effects? Many people, obviously, because these are drugs, you are worried about the side effect, but most of the time, 99% of the time, the side effect of steroid, injectable steroid is very less. Some amount of mood changes, GI disturbance can happen, fluid retention, glucose can increase, especially in diabetic, we are slightly more. Rarely infections or femur head necrosis, which are very rare. If in the acute phase, if patient is not responding to the treatment, then rarely this plasma exchange or ACTS subcutaneous injections are used. Now coming to the disease modifying therapy. So these are the therapies which are available. There are many therapies which are available. These are the therapies which modify the course of the disease. They treat the brain lesions and prevent them. So what is the main aim is to decrease the frequency, to decrease the new brain and spinal cord lesion, and to avoid the progression of brain atrophy. Because if the lesions keep on happening, then the brain shrinkage, the volume loss of the brain will happen, and which will have long-term effects on the cognition and disability. So there are various drugs available. Many people obviously read on internet. There are so many new drugs which are available. Whether these are available in India, these are all questions which I will be answering. So injectable medications are available. Like 20 years back, we only had injectable interferons, glatiramer, but now there are a lot of other options available. Oral options are available. Then infusion therapies are available, like natalizumab, alentizumab, and ocrelizumab. So talking about the oral therapies, the main group which are commonly used in India is dimethyl fumarate or teriflunomide. And the newer ones, these three names are there, which are newer ones. Fingolimod is available in India. I will be discussing about that. Ceponimod and cladribine at present are not easily available. Then there is a terminology called as highly active MS. So means the activity of the MS is high, means you need to treat it more aggressively. There are certain criteria which are not important, but when the person has MRI features and the clinical features suggestive of more aggressive course of the disease, then we use the term called as highly active MS, and in which usual therapies, oral therapies are not that much effective, and you need to treat with strong agents so that you decrease the disability. Now, clinically isolated syndrome, that is isolated one attack or early MS. Usually the first line therapies are interferon or glatiramer if it is injectable, or oral therapies are dimethyl fumarate and teriflunomide. And as per patient preference, most of the patient obviously will feel that orals are better. So most of the neurologists in India are using these two molecules in preference to the injectable molecules. Then in highly aggressive MS, as there are certain definitions for that, we diagnose basis of the MRI and clinical features. These are the agents which are available, oral as well as injectable. This is the list of drug which is available. These are the original drug names. Like it is not important for us, you to know the drug names, but then I just want to highlight that there are so many drugs which are available in India now. And these are the standard company name, but then most of them are available in India now and with much reasonable rate, what it was originally there around 10, 15 years back. And even as per the European or the US counterpart, the cost of the drug, even with the original molecule, is much less in India. And then there are certain biosimilars or generic which are available, which can definitely be given. So, the various drugs which we are talking about, they interact with the brain receptors. So some of them interferon, like usually interact with the immunity related molecules in the brain. Alentizumab, it is directed against a monoclonal antibody which is CD52. So the mechanism of action of these drugs is different. So if some person who is on one drug and there is a failure of that drug, means the drug is not effective to prevent relapse, then you can choose a drug with other mechanism of action. So this is for us as a neurologist to know that what particular action is there, and that's how we decide about the treatment part. So interferon has been used since last almost 30 years, and there are various formulations available. In pregnancy, still there is data that interferon can be used safely because the other drugs are not that much effective. So if some person plans pregnancy, then interferon still can be given. But now, of late, otherwise, in a routine practice, most of the patients do not prefer injectable. And now, of late, most of the patients are on oral drugs, which I discussed. When you give interferon, the side effects usually are, because it is a subcutaneous injection or intramuscular, usually injection site reactions, flu-like reaction, liver function monitoring is required, rarely depression. Glatiramer, again, it was available very easily long back, but nowadays companies are not promoting it and it is not easily available. Fingolimod is an oral drug available in India, but of late, because of less number of patients, generic brands have withdrawn it. It is not easily available now. And so this drug orally, whenever there is slight aggressive MS, we use it orally. We have to monitor the cardiac function. So whenever we give the first dose, it is given in the hospital, and we have to do the ECG of the patient because it can induce heart blocks. So that's why the first dose is given in hospital. The person is monitored in OPD for some time, and then regularly he can take it home. This is important because if you are considered on fingolimod, your doctor would do that ideally. Natalizumab is a drug which is injectably available. It is for highly aggressive MS. It is used. It is a monthly intravenous infusions. The only main worry in this is JC virus, which is a virus which can be there in some antibody. Sometimes after giving the drug, antibodies can develop against the JC virus, and that's why this monitoring is required. And rarely, if it happens, if the antibody concentration is more, then you can develop a condition called as leukoencephalopathy, which requires other treatment and stoppage of the drug. Dimethyl fumarate, it is very commonly used as an oral drug. The dose is 240 milligram twice daily, and it has side effect of lymphopenia or rarely PML. Teriflunomide, another commonly used drug with oral daily dose of 7 or 14 milligram. GI symptoms are there, some GI irritation or dyspepsia. It is teratogenic. So, what is teratogenic? Teratogenic means in pregnancy, if some lady is taking teriflunomide and becomes pregnant, then there is a risk to the fetus of some developmental malformation. So that's why in females of childbearing age, many times neurologists would avoid this drug, or if by chance accident pregnancies happen, then you have to, or if you are planning pregnancy, then there can be some other treatment. Means there are certain treatments available to decrease the concentration of the drug in the blood so that you can plan pregnancy in few months. So this is important to just know, because this point would be discussed by the neurologist whenever you start road. Alemtuzumab, this is another monoclonal antibody against some of the particular antigen subtype which is on the neurons, and it is available now. It is a costly molecule, but then found to be efficacious. These are all the drugs which we are just discussing. The two drugs, ocrelizumab and ofantumumab. These are ocrelizumab is now available in India. The drug which I just previously discussed, alemtuzumab, if you read that the dose in year 1, 12 milligram for 5 days, and in year 2, 12 milligram for 3 days. So total 8 days. So the feasibility of usage is definitely there. The efficacy is also there. You need to monitor certain side effects, which is with every drug which is effective. And this has been found to be very efficacious for multiple sclerosis, but the cost is definitely prohibitive. I'll be discussing the cost of all the molecules in the later slides. Then some person can have a progressive disease from the onset, that the disease started and gradually it is increasing. The disability is increasing. So there are certain treatment options for that. Mitoxantrone is one drug which is given injectable form. Ocrelizumab, which is used for relapsing remitting, also that can be used for primary progressive MS. And siponimod has also been approved for secondary progressive MS. This I already have discussed. So whenever you have diagnosed a particular person as relapsing remitting MS, there are certain points which favor good prognosis and poor prognosis. Depending on that, if it is a mild patient, if the mild symptoms are there, then the preferable agents are either injectable interferons or glatiramer acetate or oral agents like teriflunomide. But if patient has aggressive MS, then from the start, you will choose a highly effective drug, which are usually infusions or fingolimod or cladribine. And then you monitor the person with MRI as well as clinically, and thereafter you choose the next drug, whether it is effective or not. So if the disease is active, the treatment A would be, you choose the mildly effective, mildly toxic drug. If disease is better on MRI and the patient is better, you continue that. If the disease is still active, then you go to treatment B, which is more effective, more toxic, so that the disease is controlled. And if disease is still active, then you go to treatment C, which is the most effective but most toxic. So the effectiveness is also related to toxicity. So that is important, because whenever we discuss with a patient, then the toxicity also need to be definitely discussed, because if side effect happens, then definitely there are treatment options, but then we need to be aware, because you are treating a disease. You cannot if it aggressive disease there, you can have disability. So that's why it needs to be treated. Then the other approach is that if disease is active, you directly stop the disease with a very effective treatment at the first go, and thereafter de-escalate the therapy. Thereafter you go to the mild agent. So this is another approach. So this approach is used mostly in the aggressive disease if they are aggressive from the onset. Now, obviously, whenever you give some treatment, there would be a question whether if some person has no symptom for 2 years, whether you stop. Ideally, no. Ideally, the treatment is lifelong. There is no paradigm for discontinuation. If patient is doing well, drugs can be continued indefinitely. But many neurologists all over the world do observe that 2 to 3 years of good event-free progression with normal MRI, no new lesions on the MRI. Many of us do observe some of the patients who are we can monitor very closely. And we switch the drugs when patient experience the side effect of the drug one. If there are relapses on MRI or new disability, so then you need to switch to another drug. So this we discussed about the second part, that is the disease modifying therapy, which are the main agent with us. Now, the third thing comes is the treatment of the symptoms. So apart from the disability, there are symptoms like fatigue is there, depression already discussed in the prior talk, neuralgias, neuropathic pain, bladder dysfunction, bowel dysfunction, sexual dysfunction. So this all, there are certain drugs which are available in our armamentarium, which we use according to a particular patients. So tremors or ataxia is one problem. Gait impairment, so slowness of gait or stiffness in the legs, which make you unable to walk. So there are certain drugs which are for the symptoms. They do not have the primary means primary action to decrease the disease, but at least the symptoms can be better. Pregnancy MS, so this is another topic of discussion whenever, because MS is common in young women of childbearing age. So usually MS appears to have little impact on pregnancy, and pregnancy has little effect on MS. So it is okay to have pregnant if you have MS, but it would depend on the type of disease, aggressiveness of the disease. After delivery, there is some chance of increase in the relapses after delivery, but then usually during the pregnancy, the chances is quite less. So the choice of the drug would depend on the particular factors. So it can be a disease factor. We discussed that how aggressive is the disease, how is the duration, what is the prognosis eventually. It would also depend on the patient factors. Like in KEM, we don't have affording patients. So we do use drugs which are easily available, which are less cost. Because even if you give some treatment and if patient is not able to afford for a year, 2 years, 3 years, then there is no point in starting a costly treatment. So we have to choose according to the patient factors, means according to the economics. And then the treatment of factors, of course, depending on the age of the patient, sex of the patient, and the side effect of the drugs. These are all factors which are considered whenever you have some treatment. So this is the last part of the talk. So what is the cost? This cost are of the original molecules. In Indian settings, most of the costs are subsidized because most of the companies do give subsidized rate. So Tecfidra, that is dimethyl fumarate, 14 capsules, the MRP is 22,500. But then usually Indian patients are able to get the original molecule at around 11-12,000. Evonex, that is the interferon. Weekly interferon. The cost was 9,000 per injection, but now it is available in a cheaper rate. Plegrid is another form of interferon which is given fortnightly, means 15 days. So that is 70,000 per injection. Then Tysabri, which is an aggressive molecule, 1 lakh per vial, and you have to give it frequently. Then alemtuzumab, which is a very effective molecule, has been found in the studies. Many studies have been done, but then 2 of the pivotal studies have said that the effect of alemtuzumab on the disease activity is remarkable. And it is used for highly aggressive MS. So cost is 5,65,000 per vial. So obviously it is costly therapy. And usually for 2 years it has to be given. So for 5 days in year 1 and 3 days in year 2. So it becomes a costly. But then still, if patient has a proper subset of MS and if patient has no economic burden, then there are help available, and the company also do have patient programs by which you can get it at lesser cost. Then the branded generics which are available are oral drugs are available at around 4,000 rupees per month. Then ocrelizumab, which is another molecule which has been originally made by Roche company, and ofatumumab, the cost is around 5 to 6 lakhs per year. And teriflunomide, which is the oral drug, which is available, is around 12,000 per month. But then now generics are available, which are around 2 to 3,000 per month. So as we see that the newer agents, which are very used for the aggressive MS, they are very costly. But then once the usage increases all over the world, that all of the agents initially are costly, and later on, once they are out of the patent, then the cost decreases remarkably. And that's why we need to wait. And all patients cannot be offered the costly treatment. We always, usually in KEM, many patients are on teriflunomide or Tecfidra or the local generics, but that is fine. Thank you. So I just covered the broad outline. I have not covered the scientific, but I don't think for this scientific details are required of various drugs.
Yes, thank you so much, doctor. Thank you very much. I we will. I would request everyone on the who have joined the session, if you have any questions, please type them in the chat so that we can start taking them. So, doctor, can I start taking the questions?
Yes.
Yeah. So, just a minute, okay. Yeah, so Raghuraman writes, Doctor, nowadays the main problem is not relapse, just flares as episodes, and major problem, sir, is progression of disability. So I think the question is,
So
how does one handle it?
So basically, frequent follow-ups are required. So flare-ups can be because of the infections. It can happen because of some other diseases, the flare-ups. But then always, whenever there is a flare-up of the symptom, it is important to distinguish by proper examination or MRI that whether it is a new relapse. Because if relapse is there, then you need to do something about the original molecule what you are using. And it obviously requires more follow-ups and some investigations to clarify this, that whether it is just a flare-up of the symptoms of the old lesion or whether this is a new lesion. So investigations will, and treatment is more or less straightforward. If the agent is going on and there are frequent relapses or flare-ups, then if the MRI also shows progression on the prior agent, then we need to change the molecule.
Doctor, this is not a question on the chat, but I can say it's my question. The doctor regularly examines me. The tests are done periodically, all of it. So usually the doctor will say, okay, I'm neurologically stable. So, and I don't take, I'm not on any DMT just now. I've taken DMT for almost 5 years, initial 5 years, but now I'm not on a DMT. I'm neurologically stable. But, sometimes there could be a situation wherein there is so much tiredness for no reason that sinks in that, you just can't get out of the bed for the next 2-3 days for you to really recover and come out. So in these situations, can these be considered as relapses, or they are just one-off symptoms or one-off flare-ups, we can say?
So as you said that a neurologist is told that you are neurologically stable. So this statement would have come from your clinical examination and the
Yes.
MRI reports.
Yes.
So there would not have been any new lesions and there would not have been any progression in your clinical status. So
Correct.
then in such scenario, we usually consider these symptoms to be symptoms of MS, not a relapse. And like fatigue is a symptom, depression is a symptom. So fatigue can be treated with some agents. So as we discussed, I was hearing the prior talk that lifestyle changes, exercises, meditation remains important for all the symptoms of MS. But if the symptoms are intolerable or if symptoms are disabling, Then there are certain agents which can be used. For fatigue also we have some agent. For hypersomnolence we have some agents. Omega-3 fatty acids helps. Good diet and nutrition helps. So I think a stable disease with only symptoms of fatigue, you may not be qualifying for any other treatment.
Okay, thank you, doctor, because I'm sure, many patients do face this because, and it's important to understand the difference. So that's the reason I
Yes.
brought it up. Yeah. I'll take the next point is what are new therapies for secondary MS more than rituximab and methoxsatron?
So secondary progressive ocrelizumab there are certain trials which are available now. So ocrelizumab has been used in secondary progressive MS. And I think with more and more trials, I think that agent would be soon approved for the secondary progressive MS. We are using rituximab, though it is off-label use, but rituximab because it is cheap, easily available, and effective also. That's what in our clinical opinion.
Okay.
Trials also are going on, but ocrelizumab, I think, would score for secondary progressive.
Okay. So the next question is, how many years can someone take rituximab? And I have taken, I guess, 7,000 mg till now in the past 7 years.
So most of the studies, they have patients who have taken for 5-6 years also. We obviously need to monitor for your WBC count, need to monitor for your liver function test, kidney function test. But then usually we have used for 3-4 years without any failures. And all these new drugs have come in the market in last 5-6 years. So, or 10 years maximum. So, there are a lot of things which we also are, learning because these are effective and they are helping patients. So definitely in market they are available easily. But then at least for 6-7 years, there is no problem in my opinion.
Okay. You have spoken about rituximab, but one of the patients is asking how effective it is in MS.
So most of the therapies of MS are effective around 40 to 50%, and rituximab has good effect on prevention of relapses. I think, in my opinion, it would be like 40 to 50% efficacy to prevent any relapses. Nothing is 100% as of now in MS.
So the next question is, with a slow progression and increasing disability, I have limited mobility, and now other medical issues also are coming up, like high cholesterol, BP, sugar. I'm managing all with regular medicine, and I need some suggestions. How can I reverse?
So all the other comorbidities need to be treated as they are. Like if you have osteoporosis, it need to be treated on priority. If you have osteoarthritis, it need to be treated on priority because apart from the MS disability, these disabilities would also be playing in the part. Then symptomatic treatment would be important. The disability can also be because of the spasticity, which is seen in multiple sclerosis. So if we can use antispastic agents, and if gait is very disturbing, then there is drug available called as dalfampridine, which can be used. So we need to analyze what is the main cause of the disability. If it is MS only, then the treatment for MS might be changed. If it is because of all the comorbidities like osteoarthritis, osteoporosis, or other disease like diabetic neuropathy, then those need to be treated on priority basis. But eventually, the exercise, physiotherapy, physical therapy remains a very important part whenever a certain person has reached to the extent of disability.
Doctor, a little while ago, you did speak about, when uh, MS progresses and over years, of course, there could be a change in the brain volume. And I think this next question is probably related to that. How to manage brain atrophy and best practices and medications for that?
So brain atrophy is because of the disease effect. So if somebody has MS, we need to give medical treatment for it. Many people, especially I do see patients who don't want to take any treatment. But then you have to understand that this is a particular disease. If it is diagnosed, then there might be relapses. So the more the number of relapses, the more would be brain atrophy. There would be black holes. So initially the acute patch will become a scar over because the neurons over there die. If you give a steroid, it would be slightly better, but then eventually it is leaving behind some deficits. So these deficits are only responsible for the brain atrophy. So as soon as you are diagnosed, if you are eligible candidate for the treatment should be continued for long. And brain atrophy can be reversed by other things like exercises, yoga, proper nutrition, proper sleep. Because in general population also, if you want to avoid dementia, then this is the only thing which is available. Brain atrophy is because of certain reason. With age, everybody would have atrophy, but only the acceleration of atrophy should decrease. So that can be done by proper diet, exercise, and yoga.
Yeah. And so, doctor, is it fair to say that when you have when one has an MS attack, and this I talk from my personal experience, there is loss of multiple things. Certain functions will get impaired. Some things come back to you automatically, but there could be some loss of cognitive functions also. But I think doing certain exercises and retraining the brain uh, is possible, because I thought I worked that way 16 years ago when I had my MS attack. But for me, I did it with my own layman's understanding that okay, I can form the new channels that have already broken because of the lesion. So let me start practicing and creating my new channels in the brain. That is how I articulated it for myself. So, but as a neurologist, I would like you to talk about this, because there is when someone gets MS, there is a lot of helplessness and hopelessness that sets in, and to deal with helplessness and hopelessness, one has to look for hope. And that hope will happen when yeah, I can still work around with it. So is there a possibility that that people can do workarounds and relearn things?
Yeah, so nowadays, because there are effective therapies available, most of the patients, even my patients, are mobile. They are working well for many years, and I don't see any problem. Rarely we do deal with person who has quite disability from the onset, and I think the disability can definitely be reversed by agents, which I talked about. But then there is a phenomenon of neuroplasticity in the brain, so brain also recovers.
Yeah.
So from that patch, the surrounding area does take the function. So even if you have disability with proper physical therapy, and so the symptom would depend on where in the brain the lesion has happened,
Yeah.
where in the spinal cord. So all the symptom would depend on that. But then with proper physical therapy and cognitive therapy, those functions can be definitely reversed.
Yeah, thank you, doctor. Jayashree's question I have not understood. She says, "Sir, MS patient not take second baby." So I don't know what.
No, I think we discussed about this with pregnancy.
Yeah.
Still can be planned with proper discussion with the neurologist. If you are on certain drug which can be teratogenic, then can be changed to some drug which is slightly safe. At present, we are using interferon in pregnancy. For 9 months, you need to take injections, and thereafter again we can shift to the original agents. Some people who are very stable, you can go off drug and plan pregnancy with understanding that if relapse happens, you need to take steroids. But
Yeah.
then can be done.
Yeah, I think this question you have already answered, but I will just read it. What are new therapies for secondary MS other than rituximab and
Yes, I
methotrexate? You
told that
spoke already about it.
ocrelizumab is one of the drug which
Yeah.
is.
Yeah. And Joshri writes, I have RRMS and have been on Avonex since last 4 years without relapse. Can I expect to come off Avonex anytime soon?
So as we discussed in my slides also, that ideally we should continue. But if your disease activity is nil, there are no lesions for many years, then we can discuss with neurologist and we can try without that and monitor you very closely for development of any symptoms or relapses. But then ideally, because the natural history of the disease say that relapses can happen. So if there are no side effects of the therapy, or if you are you can afford to continue that, it is better.
The next question is also something that you addressed a little few minutes ago, that, does exercise or physiotherapy exercises slow down the progression of the disease?
Okay, so it is very important. Exercise and physical therapy does have some effect because the chance of relapses become less. If you are physically and emotionally fine, then the chance of relapses also decrease. As we know that the relapses can happen because of the originally the disease only itself, there are genetic factors and environmental factors. Then there are viral infections which have been implicated. That this particular virus, like Epstein-Barr virus, many people feel that it is the Epstein-Barr virus which causes MS. So there are various environmental factors, genetic factors, viral infections which can trigger. So with proper exercises and proper diet and meditation, definitely many of the symptoms of MS can reverse and the acceleration of progress can decrease.
Okay. I may repeat because I don't want to miss on any question, and I don't want anyone to be felt left out also in the session. So, been on various DMTs since 10 years, many relapses but no disability. How long do to be on DMTs? Which you said you should be as long as you can.
Because you have multiple relapses in 10 years, so I think it should be continued.
Yeah. Then the next from Deepak is our phase 3 BTK inhibitor trials safe?
So, so nowadays, like this eponymod and they are all BTK inhibitors. So trials obviously are trials. You do monitor whenever some person is in trial for the MS drug, you do monitor hell lot of things from the blood. So trials, out of 15 or 50 to 100 drugs, one trial would be positive. So trials eventually are trials. So trials as such, when there are no options, and if you are in that category when this drug can be effective, because always the initially are the laboratory, then animal trials, and thereafter human trials. So if trials are eventually experiments, but then they are experiment with lot of monitoring. So we also do trials, and we have to monitor the patient. There is proper consent procedure, and thereafter, so trials are safe because you are monitored very rigorously for any side effects, and if there are certain effects found, then the drug is stopped. And most of the drug, fortunately, the effects are not permanent.
So the next one is, I'm doing good. Corona in 2021 greatly affected my symptoms. What are your views and experience with patients, sir?
So in Corona, unfortunately, there were not proper guidelines. Many patients did had relapses also and were untreated because it was a new disease for everybody of us. And many patients, because MS is also supposed to be immunosuppressive state, so the severity of Corona was also more in patients who had multiple sclerosis. So my view is that COVID has not changed the frequency of MS. COVID has not changed the symptoms of MS. The MS was there and still it is there. There were certain other diseases which mimic like MS, which were more frequently seen in COVID, but then eventually our practice parameters have remained same.
The next is, I'm on dimethyl fumarate, unable to walk now. Should I go for steroids or other injectable medicines?
So first thing is to determine whether, as I discussed, the first thing is to decide whether it is a relapse or not. So it would depends on the if MRI shows a new lesion appropriate for your disability, then it should be treated with steroids. And if it is very long standing, then probably it just needs some more amount of physical therapy. If it is there are no new lesions on MRI, then it can be just a symptom which is of old lesions, and it can be treated with either symptomatic treatment or with proper physical exercises.
Yeah. So the next one is, I take 5 doses of rituximab, and my doctor said 6 dose maximum. So what to do next?
No, if disease requires more than that, then it has to be continued. 6 dose maximum, I don't think there is any criteria. If it is in mind that disease activity, so as we discussed that there is a de-escalation therapy. So sometimes if the person is very aggressive disease, you give rituximab in the starting, and then if disease is stable, then you come to the lower agents. So that is one thought which can be there. Otherwise, if you are doing well on rituximab, that also can continue. Or switching to some minor agents, milder oral agent.
Doctor, the next one is living with limited mobility and weakness in both lower extremities. Problem is in bladder and difficulty in urination. Urine tripping is more of a concern.
So there are certain symptomatic treatment which we do give for the bladder symptoms. If it is a retention, then self-voiding catheters are there, which can be inserted. If it is a incontinence, then there are certain drugs which can help, which neurologist and in combination with urologist would help, because sometimes there, a person feels that it is all neurological, but sometimes there can be local cause. So a gynec or a urologist also we do involved in the care. Most often it is because of MS, but then in elderly or if you are having quite severe relapses, there can be additional problems. So it is a proper examination and diagnosis, and thereafter certain symptomatic treatments are available.
On 8 to 10 years in RRMS is converting to secondary progressive for all. I mean, after 8-10 years, does RRMS convert to secondary progressive for all? And now after 8 years, my disability is getting or is increasing without any relapse.
Yeah, so it's not for everybody, as I told, that everybody will develop secondary progressive MS. Some people are stable even after 15 years of diagnosis. So it is the individual susceptibility to the disease. If there is a secondary progressive MS and the disabilities are accruing, then there are certain other agents, as we discussed, which can be given.
So next one is, I have new symptoms, but MRI shows no new lesion. Still, do I need to take to have steroids? So I think probably the first one that I asked.
Yeah,
There are
so
symptoms.
MRI does not show any lesion, but then there are new symptoms. But then the symptom need to be determined if those symptoms are very typical of MS, and MRI with a good quality MRI, because sometimes MRI in periphery is not to the extent. So we do a proper MS protocol MRI with good contrast. So MRI, there are also there are various centers which are doing low cost MRI, but then for MS, I would feel that a good quality MRI should be seen. And if it also does not show any relapses, then we should treat you with the symptomatic management, not with the steroid.
Yeah. So the next one was is Copaxone a low efficacy or a high efficacy drug?
Okay, so it has moderate efficacy, but then it has been less used now. I personally do not have much experience of its usage, because there are other agents available, but then it has a good efficacy for control, but it is injectable.
Yeah, I will read one more question. I see Deepak has raised his hand, but I'll finish what is on the chat first. For a person like me approaching age 60 and have MS for 20 plus years, is going for high cost medicines worth it at this stage of life? And this is a serious decision on a no job scenario.
Okay. So at the age of 60 with 20 years of diagnosis, we need to see whether you have a secondary progressive symptoms at this age and your MRI is still active. If MRI shows activity and if you have no contraindications, medical contraindication for the aggressive therapy, then yes. Otherwise, if your MRI is stable and if your disease is stable and the disability is not progressing, then the same drug what is going on should be continued with monitoring of the other factors which are common at this age, like blood pressure, diabetes, osteoporosis, other diseases.
Yeah. Deepak, you had raised your hand. Do you have anything more to ask?
Uh, okay, I have a doubt. Actually, I have MS from past 5 years. So on rituximab, I had two relapse. I don't know what we'll call it as pseudo relapse or Uthoff's phenomenon. Third relapse, C2T11. Fourth relapse, C7 spine. So, in spite of these two episodes of attacks over there, can I still continue rituximab or have to switch to high efficacy? Yeah?
So because you have relapses and good number of relapses on rituximab, agent need to be changed. That
Okay,
I
two
think,
relapses on rituximab. I don't know what you call Uthoff's phenomenon. Two
and
relapses, I don't know. C2 relapse,
no.
C7. Okay.
So Othoff's phenomenon would not be considered relapse, but then if there are two relapses and MRI also does not show NIDA. NIDA is no disease evidence of disease activity on the MRI. If MRI shows new lesions and if your rituximab you have been given for like more than 1 year or 2 years, then some other agent need to be used.
Okay. I've been rituximab from past 2 years. Okay, fine. As per you have to switch
Yeah.
to the other drug, right? High efficacy.
Yeah, because 2 years have happened and new lesions are happening, then I think we need to see them.
Okay. Okay, doctor. Thank you for your inputs.
Yeah.
Yeah. Does anyone have any further questions? So, Doctor, I don't think we have any more questions.
Yeah.
But let me, before I conclude, I would like to thank you wholeheartedly for giving your precious time uh, to, give us the entire overview of what are the therapies that are available and how we could, go about with our disease and choosing these therapies. And I'm sure, the doctors that handle us know the best for each one of us. So thank you once again on behalf of all the patients that have joined here, on behalf of MSSI, Mrs. Sheila Chitnis, and myself personally. Thank you very much for joining us for this. Uh, Yes, Harita, you said something?
Yeah, sorry for disturbing you. Is physical therapy and exercise mean the same?
No, so they are slightly different. Whenever you have a disability, if you have a disability, like if you have a spasticity or a weakness, then initially physiotherapy is done aggressively. Physiotherapy involves the active, passive or active movement of the muscles.
Okay.
Exercises after that initial phase of physiotherapy, if your power is improved to a good extent, then you do continue to use those muscles in different form of exercises. So I won't think that exercise you do it yourself. Physiotherapy initially, at least initially, you need to be under certain guidance, and thereafter you can do on your own.
Okay. Okay. Thank you so much, sir.
Yeah.
Oh, okay. Yeah.
Yeah. Uh, 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 Mrs. Chitnis, you're on mute. What were you saying? You'll have to unmute
I'm
yourself.
saying I'm really thankful to Dr. Neeraj because I know how busy he is in the KM hospital, so many people and he's never ever able to take a call or anything, and still he has come and spent Sunday morning with us, Saturday, even Saturday. So Saturday you are working, no, I feel. So
Yes, yes.
thank you so much.
Thank
Thank you,
you.
Neeraj.
Thank you for inviting me. I like the session.
Mm.
Thank
Yeah,
you.
and thank
It
you.
was
Before we
very nice
close,
session, and Kranti, you have done very well. Like
uh,
you are also very professional.
thank you.
Very
So
nice,
before,
very nice.
yeah,
I am very happy with you for both the sessions. It was wonderful webinar. I'm happy that MSSI Mumbai could, uh, I mean, organize this one. Thanks.
yeah, and so, formally, I would like to thank the
Thanks.
MSSI Mumbai team. Each of them has put in a lot of effort in sending out invites, following with all the people that are required to, make this webinar a success. I would like to thank all the patients and all the other people who are not patients who have joined this webinar today, because the webinar is of no use if you all do not join. And I sincerely hope that you have uh, had something personally to take away from both the sessions today. So thank you very much for joining the webinar. I would like to thank Roche as our support partners in this whole endeavor, and everyone, the national team, Javed, who is our technocrat behind the entire infrastructure that he
Yes, yes.
provides to us. So thank you, everyone. Thank you for joining in today. So it was a
Thank you.
wonderful morning today. Thank you very much,
Thank
everyone.
you.
Thank you,
Thank you.
Doctor,
Thanks.
once again.
Bye.
Yeah,
Thank you.
thank you.